It's an annual symposium. Unfortunately, last year, due to the COVID, we weren't able to proceed with our plan. So this is our first virtual event. So forgive us if there's any glitches along the way. But I just want to welcome everybody and thank you to all the speakers and all the volunteers, all the people that help in the background to make this event possible. I hope everybody's able to hear us well. This event is being recorded. So after the symposium today, everybody will get an email with the link that they can review the information at any time. During the symposium, if you want to talk or have a questions or send a message, don't forget to use your chat button at the bottom of the screen. And there's also a Q&A click or a tab as well. You can send us messages through that. We're very excited to bring this presentation to you. We have so many amazing presenters today. And with so much expertise that I would love to be able to share all of that to all of our community. Just a few questions, just a few technical stuff, I guess. The agenda today, you should have had it on your link, but I will also go through it a little bit to give you an idea. We do have a break at the middle of the symposium today. Let me try to share you my screen. So this way it would be helpful for you can see what's going on. Let me see here. Okay. All right. Is everybody able to see my screen? Okay, good. Again, welcome. This is a virtual conference this year. This year, I actually have a few helpers from my colleague, Deanna Merrill and Jessica Aparicio. They will help me. It's nice to have additional people to help me with the conference, and I don't have to come up with all these ideas by myself. So welcome to Deanna and Jessica. Deanna will be our moderator today. Jessica will come on toward the end to close out our symposium for the day. Today agenda at the beginning is just the welcoming, and then we'll have a short video from our MRF CEO, and then follow that by Dr. Kendra, and then our speakers, starting with Dr. Wu, and then the dermatologist, Dr. Spaccarelli, Dr. Puchikal, and then our pharmacist, Dr. Archambault. We have a break at 10:50, 45 to 10:50, just a 5-minute break to give everybody time to stretch. And then we resume again with Dr. Blakai from radiation oncology, Dr. Contreras from our surgical oncology, and then Jessica will close out the event. I just wanted to let you know that we do have a melanoma support group here. Unfortunately, it's not in person at this point due to COVID, but we will resume it as in person again as soon as all the limitation is lifted. But you can go to cancer.osu.edu/support groups for further information. Again, I wanted to like to thank all the speakers, the sponsor, and the volunteers to help today make it possible. Without all those man hours, we wouldn't be able to bring this to you. May is, of course, skin cancer awareness, so it's perfect for our symposium. I just want to make everybody aware and spread the word out there for skin protection. And of course, you can't have May awareness without reminding to protect yourself. So I love this slide. I use it in all my presentation: slip, slop, slap, seek, and slide. So just to have a perfect protection for the summer. Well, one thing, I just want to remind you, unfortunately, this is a virtual symposium this year, so we don't have the patient testimony part, but I'm hoping to bring it back at the next symposium. We do have it saved at this time on Saturday, May 7th, back at our own facility at Eye and Ear Institute on Olentangy. So if anybody out there who would love to be able to share your story for the next year's symposium, please don't hesitate to reach out to me. And I would love to have as many panelists or as many patients on the next live symposium. Okay, and then in conclusion, I just want to thank you everyone for being here. And you can also visit our website, cancer.lsu.edu, for further information. At this point, I am going to stop my sharing, and we are going to go to our next part of our agenda. And I would like to introduce you to, and forgive me, I hope I'm not pronouncing her name incorrectly, Kylie Lipera. She's the MRF CEO. And I am actually going to turn this over to our Leanne so she can play the video from her.
Hello, and welcome to the Melanoma Research Foundation Patient Symposia Series. My name is Kylie Lipera, CEO of the Melanoma Research Foundation, and I would like to officially welcome you to today's event. I'd like to now take a moment to walk through a little bit more of who the MRF is and what some of our programs are for the melanoma community. So to start off, I'd like to talk a little bit about the MRF's history and mission. We were founded almost exactly 25 years ago by a patient. Her name was Diana Ashby, and she was experiencing her third recurrence with melanoma. And 25 years ago, unfortunately, there were very limited treatment options. It was out of this frustration by the lack of availability and the lack of investment in research that she decided to form the Melanoma Research Foundation. Unfortunately, Diana passed just before the MRF gave out its first research award, but it was her advocacy and dedication that launched who the MRF is today. Over the years, our mission has changed a little bit. When we began, we were really the only funder in the private space funding melanoma research. But as we learned over the years, education and advocacy are equal parts as important for the MRF. So that is why our mission today is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. I'd like to touch on each tier of our mission just briefly. As I mentioned, we are a research funder. And in fact, to date, we have funded over $20.1 million in research awards. That's been over the last 24 years. That's resulted in 233 projects, and we've spanned over 80 institutions in 31 states and the District of Columbia. As I mentioned, we do fund research grants. We also have a breakthrough consortium, which is a partnership among academic centers of excellence to collaborate on research projects. We also fund the rare subtypes. Our ocular melanoma program, or the CureOM initiative, is very active in terms of funding research and also supporting newly diagnosed patients and their families. We also have a focus on the other rare subtypes, such as mucosal, acral, and pediatric. We also focus on special projects. Most recently, we held our third Brain Metastases Summit. Education, or the second tier of our mission, is equally as important in our eyes. To educate patients and caregivers wherever they are in their melanoma journey, as well as the general public, about prevention, diagnosis, and treatment. We host a variety of educational events throughout the year. Many of these are in person and virtual now. We have online education. We provide free printed material for anyone who requests. We host webinars, which are both live and on demand. We've created animated melanoma patient videos to take the most complex scientific concepts and break them down into short 3-minute videos that are easy to understand. We also have a patient and caregiver online forum where patients can connect with one another and ask questions and get support. Advocacy, or the third tier of our mission, is equally as important. We serve as a strong advocate for the entire melanoma community, both on the federal and the state level. Our work culminates each year in March for a virtual this year, but hopefully in person, Hill Day going forward, where advocates are able to meet with their state representatives, share their story, and urge change. We have advocacy toolkits and very frequent call to actions for our community, so we hope you'll get involved. As I mentioned earlier, the MRF gave its first research grant out almost 24 years ago, and a year before that, the foundation was established. So this year, we are celebrating year-round our 25th anniversary. We encourage you to get involved, become engaged in some of our educational programming, and find ways that you can stay connected to the melanoma community year-round. Lastly, I'd like to thank our sponsors for their ongoing support of the MRF's educational program, our gold level sponsors, Bristol Myers Squibb and Merck, our bronze level sponsor, Alkermes, our friend sponsor, Novartis, and our industry startup sponsor, Oncosec. A big thank you for their financial support. And lastly, we just wanted to share a few ways that you can connect with the MRF via our social media channels. And of course, if you have any questions at all, please feel free to reach out to our education department at education@melanoma.org. Thank you.
Thank you for that. We're going to go ahead and move on to our next part of our symposium, at the start of our symposium. Let me hear this. Okay. I'm very happy to introduce Dr. Carrie Kendra. She is the leader of our Melanoma Disease Pacific Committee and our team. Her clinical expertise are in melanoma, which include cutaneous, mucosal, acrolentigenous, desmoplastic, ocular, and clinical researches. Her interests are also in basal squamous carcinoma, basal cell carcinoma, Nevis syndrome, Merkel cell carcinoma, squamous cell carcinoma, and Bowen's disease. And also, she was rated the top 10% of our physician in the nation in 2016 and 2017 for patient satisfaction. With my pleasure and honor to introduce you to Dr. Carrie Kendra.
Good morning, everyone. I'm just going to upload my slides here. Again, I do want to say a thank you to MRF, to OSU, and to all the work that Fung and everybody has done to put this symposium together. It's been a symposium that's in place for many years, and many people benefit from it. And so I'm very, very pleased and honored to be able to participate in it and to work with the wonderful people that we do within our program. As the keynote speaker, I'm going to take a different approach than I've taken other years, and I'm going to start out, whoops, by changing the slides. There we go. We know that COVID-19 has hit us all. It's been tough. There's a lot of fear, a lot of loss, a lot of struggle, loneliness, sadness, and unknown about what the future is going to bring for all of us. We know that the COVID-19 is an ongoing event that has changed our lives. It changes at how we look at the world, how we live in the world, and how we face the world day to day. I want to start by just asking for a virtual moment of silence for all those who have lost someone or something due to the pandemic. The old, the young, the frail, the strong, and those who are struggling to survive all need strength at this time. So we're just going to have a moment of silence. Thank you. What I've learned from the COVID-19 is that it's taught us so many things. It's taught us what's important in life, who is important in our lives, and what is of value to each of us as individuals. There are, oops, I'm sorry, I need to go back. Sorry, I'm not used to all these extra pieces. There are some incredible people in this world who continue to amaze me. Those who serve as a frontline medical workers who are in the hospital taking care of the sickest of the sickest, the teachers who are trying to keep our children moving forward in the world of chaos, and those who demonstrate kindness to each other, the neighbor who drops off food at someone's door because they're afraid to leave their house, the individual who calls someone and teaches them on how to do the virtual calls, even though they've never done them before, just so they can have some social contact. There are a lot of things that I've learned through the pandemic, and I hope other people have as well. Oh, I'm sorry, we're not there yet. I apologize for my poor slide technique. I'm just gonna start from the beginning in advance because I can't do this. Okay. COVID-19 and cancer. We know that there are some cancers that are impacted more with the virus. Those are the hematological malignancies and lung cancer. Those individuals tend to do more poorly when they've been infected with the virus. We know that COVID-19 has impacted screening for early detections of cancers. And with that the early diseases in their earlier stages has been delayed. And unfortunately, cancers are being found in their more advanced stages. We know that because of the pandemic, therapies have been delayed, in part to minimize risk of exposure, in part because of active virus infections. And we have to begin to change this. We know that research being done with cancer has greatly contributed to the rapid development of the coronavirus vaccine. The MRI platform enabled the development of the first COVID-19 vaccine and had been built on the prior testing of mRNA vaccines for cancer over the past 10 years. So at this point, we've been strongly negatively impacted by COVID-19, and we have to move forward. We need to move forward to begin our screenings, to find out ways to do them safely and carefully. We need to move forward with our therapies so that we can again make the achievements that we have with the wonderful therapies that we have. And we need to continue to move forward the research that has taken us to where we are now and to help move us further in the future. With focus, funding, and inquisitive minds, we can achieve. We see it in the rapid development of the coronavirus vaccine. While not perfect, we see it in the vaccination of so many in a short period of time. And we can make these achievements happen in the melanoma world as well. So thank you. Enjoy the meeting. And the speakers will continue to show you all the wonderful things that are happening and continue to happen for melanoma.
Dr. Kendra, you can continue with the program with Dr. Wu, introducing Dr. Wu.
Oh, okay. Okay. Well, then I'd like to introduce our next speaker, Dr. Wu. He's a new faculty member who has joined our practice, focusing in on cutaneous malignancies. He is one of our medical oncologists and has done some very, very interesting work on cell-based therapies and is looking to bringing many of those approaches here to our patients. So Dr. Wu, we welcome you.
Thank you, Dr. Kendra, for the nice introduction. Let me just get my slides uploaded and we'll start. Are we able to see my slides? Okay. All right. So I'm one of the faculty members in the cutaneous oncology programs at Ohio State James Cancer Center, and today I'm very honored to give you a overview of the present and also the future therapies for melanoma. Just move on to my next slides. So this is my presentation outline. I will discuss some of the incidence, epidemiology, risk factors for melanoma, and some of the signs and symptoms to watch out for, and also how we do stagings, when we see patients in our clinic. And I also discuss some of the current treatment options as well as some of the future ones, and also some of the clinical trials that we have going on at the James. So melanoma is a cancer of a type of a pigment-producing skin cell called melanocytes. And melanocytes are basically the type of cells that their function is to protect us against the UV radiation from the sun or water sources by producing the skin pigments. It's so if you look at all the skin cancer types, it's about 3% of all the skin cancer. However, because of its aggressiveness, it accounts for the majority of the mortality and morbidity associated with the skin malignancies. And this is the latest data from the American Cancer Society, where they estimated that there will be probably around 100,000 combined cases between with all the males and females patients combined in 2020. and with the estimated number of deaths that I've shown in the slides. And, this is also the data from CDC, which show that that the melanoma incidence does increase with age. And I think it probably has to do with the fact that the older that you live, the more sun exposures you have. So therefore, it's that's why this is a very nice correlation with the age. And this is also an estimate from the CDC, which they're showing that the incidence of melanomas are increasing every year. And from 2015 forward, it's estimated that 1 in 50 Americans will develop will have a lifetime risk of developing a invasive melanoma. And as to some of the risk factors, it appears that the Caucasian patients are more vulnerable to melanoma, whereas the other ethnicities are a little less at risk. And I think it probably has to do with the fact that in Caucasian patients, their melanocytes produce much less pigments compared to other patients, and therefore that makes them more sensitive to the UV radiation from the sun. And the other risk factors that I frequently talk about with patients in my clinic are patients that have fair complexion, people that have blonde hair, blue eyes, and also those patients who have a tendency to burn when they're exposed to the sun rather than tan. And yeah, these are some of the patients with different skin types that we see in our clinic. And one of the key risk factor for melanoma is for patients who have had skin that are repeatedly damaged by the sun. And as you can see in this patient who have developed a very extensive sun damaged skin, those patients are at a very high risk of developing melanoma. And there's actually a very nice tool that was developed by the National Cancer Institute, where you can actually go through a series of questionnaire and that will that was calculated at the end that can help you estimate what's your lifetime risk of developing melanoma, and then look at the different criteria such as the gender, the ethnicities, the age, and also how many moles you have, and also what's your skin type. And I think it's a very nice tool for our clinic, for our patients to be able to kind of estimate what's their chance of developing melanoma in the near future. So what does melanoma look like? So I'm going to go through a series of pictures for the appearance of melanomas that we frequently encounter in our clinics. So in terms of the distributions, in male patients, we frequently see that that the melanoma presents on the back or neck areas. And I think a lot of times the story I often heard in my clinic is that that these lesions were picked up actually by by their significant others, because as men we are oblivious to our skin lesions at times. So that's why it's important that that we have also someone else just take a look at our skins from time to time. And for women, I frequently see melanomas that's on their on the back as well, but also on the lower leg. And I think some patients may have developed melanoma in the lower legs from the tanning bed use. So that's why I frequently counsel patients to really avoid the use of tanning beds, because it's really one of the major risk factors for developing melanoma. And this is an example of the patients that we sometimes encounter in our clinic who comes in with these neurologic symptoms and also a very suspicious looking skin lesions. And so it turns out that this patient actually end up having a melanoma that has not only spread to the lower part of the skin, but also has spread to other places as well. So one of the mnemonic that I want you to remember that can alert you of a possibility of melanoma is to look for is A, B, C, D, E. So the A stands for symmetry. So when you look at the mole, if one side of the lesion is different than the other side, then that's also then that's very suspicious. And also if the border is like rugged or irregular. And C stands for color. So if the color is changing from, let's say, like from like dark or all of a sudden to blue or to red, then please let your dermatologist know to take a look at it, or us. And D stands for diameter. So if these lesions are growing, then their diameter is going to increase in size. But I think of all the mnemonic, I think the most important is E. So basically, any lesion that's changing in size, shape, and color should be brought to the attention to the dermatologist or UPCPs. Yeah. And these are other different types of melanoma that we see in the clinic. There's superficial spreading, nodular, lentigo maligna, acral melanoma, and also other more rare subtypes. And these are some of the images that we encounter. So for the superficial spreading melanoma, the melanoma is actually spreading on a horizontal plane as opposed to a vertical plane. And sometimes the melanoma can appear in some unexpected places like the scalp, and these are some of the locations that are very commonly missed. So, and for the nodular melanoma, these melanoma actually grows vertically instead of horizontally, and because of that, it actually carries a much higher risk of invading into other places in the body. And lentigo maligna melanomas are basically melanoma that arise from the chronic sun-damaged skin. And the melanoma that arise in the extremities are called the acrolentigenous melanoma. And I mean, I would say that this type of melanoma sometimes arise, very insidiously in darker skin in the individuals, and sometimes they're missed because of that reason. And desmoid pass melanoma is a rare type of melanoma, but it's the most often mistaken for just a benign skin nodule because of its appearance. Again, if you notice any lesion that's like getting bigger and changing, regardless of its color, you should definitely make sure to bring to the attention of your dermatologist or PCP. Yeah. And sometimes we see melanoma patients who actually had melanoma metastasis underneath their skin. So this is an example of patients that we sometimes see in our clinic. So in terms, so staging is a very important part of determining the our patient's prognosis and also most important the treatment options. So staging is so the older system that was used before is called the Clark's levels. Nowadays we use a different system looking at how deep the melanoma has invaded into the skin, and it's an actual measurement that's reported in millimeters called the Breslov depth. So this is a staging system that's the most recently developed by the American Joint Committee on Cancer, and right now it's at the 8th edition. So the staging system is taking into account 3 different systems. So T stands for the size of a tumor. And so the T staging is depending on how deep the melanoma has invaded into the skin via the Breslov depth. So for T1 lesion, it's often 1 millimeters or less. And T2 is between 1 and 2, and T3 is around 2 to 4 millimeters, and T4 is more than 4 millimeters. And toward the later part of the presentation, I'll show you some pictures of what that means. And for the end staging, it's based on how many regional lymph nodes are involved. So if it's 1 lymph node that's involved, that's M1. If it's 2 or 3 lymph nodes, that's N2. And if it's 4 or more, then that's N3. And we have a subnotation, subdivision to indicate whether these lymph nodes were picked up by the pathologist or by clinical exam. So if it's a microscopic invasion, then that's an A substation, and whereas B that's a clinically palpable lymph nodes. And we also have additional C to indicate a specific feature of melanoma, indicating that it has transited away from where it starts, and those are called the in-transit lesions or satellite lesions. And lastly, the M stands for the presence or the absence of metastasis. This is a very important part of staging for us to distinguish between for a patient with stage 3 cancer versus stage 4 cancer. So also for M, it's basic indication that whether the melanoma has traveled to distant organs such as the lungs, the brain, or even forming these like skin nodules that I've shown you before in the previous picture. So basically, taking into account both information from the tumor staging, the lymph node staging, and also the presence and absence of metastasis, then we can put in all this information together into a grid where we can actually where we can arrive at the exact staging for the patient's disease. And just as a pictorial presentation, the T1, this is the 1A, stage 1A tumor is really the earliest tumor that can be diagnosed, and it's 1 millimeter or less and has no ulcerations. And 1B is when it's 1 millimeter in invasion and but also has ulcerations. And T2 is when it's more than 2 millimeters. And on the right hand side, these are some of the representations for the stage 2 melanoma of the different combination of features that will lead to the different staging within the stage 2 system. So let's talk about the different treatment options for melanoma. So for the early stage, like the picture I've shown you in the previous slides, it's often when the lesions are less than 1 millimeters in depth, oftentimes by taking out the lesions through a surgical excision, a possibility of a long-term cure can be achieved. And Dr. Contreras, our surgeons, will also discuss with you in detail of what that entails. And for the more locally advanced tumors, such as those in the stage 2 and 3 category, they will need a combination of excision of the primary tumor, but also an evaluation of their local regional lymph node status called the sentinel lymph nodes. And that is a very important information to determine the further therapy options. And for stage 4 therapy, the surgery is not the primary mode of therapy. Instead, it's the systematic therapy that is aimed to control the disease for long term. And these are so for the early stage tumors that we aim to at least have between 1 to 2 centimeters of surgical excisions. And I think our surgeon can also discuss this more in detail. And for the stage 2 or 3 cancers, we offer sentinel lymph node evaluation is a very important part of the prognostic and also therapeutic decision making. And there's actually a very nice tool developed by the Sloan Kettering where you can actually put in some information based on the pathology report of the tumor. And that will give you a very nice estimate of what's the chance that the melanoma has traveled the sentinel lymph nodes. So for stage 3 patients, why do we discuss systematic therapy? And so I often discuss the systematic therapy with the patients in my clinic based on the data from the AJCC 8th edition, where they actually follow these patients where they had where they have the surgery, and then they're followed for up to 10 years now without any additional therapy. And as we can see that for patients at the 3A disease, they can have roughly close to probably 10% chance of recurrence, whereas with stage B, C, and D, those chance of recurrence increases significantly without further therapy. So one part of determining the therapy that we give after surgery is to look at the patient's mutation status. So it turns out that in Caucasian patients, about 40 to 60% of the patients have a mutation in a gene called BRAF. And that's one of the genes that's driving the tumor growth. And that can be potentially targeted with the therapies that we'll discuss in the next few slides. And there are also other mutations in melanoma, such as NRAS, c-KIT, and CDK4, that can also happen as well. Although there's currently no effective therapy options for these other mutations. So one of the therapy options for the patients with BRAF mutations are these targeted therapies, and they have been developed by 3 different companies, and they all have very similar side effect profiles, and there are some distinct side effects with certain therapies that can be a bit different than others, and that's something that I always talk, that if you're in my clinic, that we always talk more in details. And the other therapies for that's applicable for both the BRAF wild type and also BRAF mutate patients are these really exciting class of therapy called the immune checkpoint therapy. So the way that this therapy works is that is by taking the break of your cancer-fighting T cells. So what happens is that when these T cells encounter a tumor, they're often they're often suppressed in their killing ability by the tumor cell through a molecule called PD-1 or CTLA-4. So these therapies are basically monoclonal antibodies that bind to that block the interaction between the PD-1 with the PD-1 from the tumor cells and also the other molecules that interact with the CTLA-4 on the T cells. So by doing that, the brake are taken off these cancer-fighting T cells, so T cells can do their job. And some of these therapies, you may have seen that in the pharmaceutical ads on the evening news, for example, and they're and those are Yervoy and Keytruda and Opdivo, or ipilimumab or pembrolizumab or nivolumab. And the use of these adjuvant therapies for stage 3 patients have shown to decrease the risk of recurrence about like 50%. And these are trials that have been published in top medical journals. And this is a very valuable option for our patients. And I think this is really the best that we can offer in terms of the adjuvant therapies that we give the stage 3 patients. So moving on to stage 4. Back in before 2011, the best options we have for patients with stage 4 melanomas are basically a chemotherapy agent called dacarbazine, and also another immunotherapy drug called IL-2. However, they are plagued by the low response rate. In 2011 has been a very important year for the treatment of melanoma, and that was because of the FDA approval for the targeted therapies such as the brafenib, trametinib, and also some of these really exciting immune checkpoint therapies such as ipilimumab, pembrolizumab, and the nivolumab. And since then, it's followed by the approval of a cancer-killing virus called T-VEC in 2015 by the FDA, and also 2018 with another newer targeted therapies for melanoma in 2018. And T-VEC therapy is it's interesting. It's basically a modified herpes virus that's injected into the cutaneous tumors, and they selectively kill cancer cells while sparing the normal cells. Okay. So why are we so excited about immunotherapy? So if you look at this patient's survival curve, it turns out that although immunotherapy has a lower response rate compared to other targeted therapies, you see this tail end of a survival curve, which is elevated, and that's an indication that there are some patients who responded that end up surviving long term. Whereas if you look at the targeted therapies, there are more patients responding in the beginning, but then oftentimes the therapy stops working about after a year or year and a half into the therapies, and you see the patients relapsing. So the potential for immunotherapy to induce a long-term durable response is very exciting. So one of the most famous recipient for the immunotherapy is former President Jimmy Carter, and he actually had the melanoma that went to his brain, so it was a stage 4 melanoma, and before the immunotherapy, these patients will only have prognosis probably between 3 to 6 months. And his disease was actually diagnosed at the time when Keytruda was first approved. So the doctor gave him that treatment, and he had a complete response. And this is a story that I often tell to the patients in my clinic. So so the promise of immunotherapy is very, very exciting, especially in the treatment of melanoma. So I would say that for these newer immunotherapy drugs like pembrolizumab and nivolumab, they're very well tolerated, although there is a small percentage of patients, 5 to 10%, sometimes they can develop these autoimmune side effects where the immune systems are actually attacking other organs instead of tumors sometimes. And these are they can potentially affect the lungs, the thyroid gland, the liver, the skin, or the joints. And again, the way that we manage them is really based on the severity of these symptoms. So I want to spend the last few minutes talking about the future of therapy for the stage 4 melanoma. Okay. So one of the really exciting advancement is the use of a type of therapy called TIL therapy. And these are basically the cells that's expanded ex vivo from the tumor, and then they're expanded in a culture for about like 2 or 3 weeks to billions of cells, and then they are then infused back into the patient. This was a protocol that was initially developed at the National Cancer Institute by Dr. Steve Rosenberg, and we have since then brought this protocol to the Ohio State James, and we're definitely very excited to be able to use this clinical trial protocol for our patients. And this was an example of a patient that was treated at NCF where this patient had a very large neck tumor, and this patient had a complete response after the TIL therapy. And these are the other ongoing trials at Ohio State James for the different melanoma patients with either with the BRAF mutations or without it. And we can certainly talk further about these trials, when you see me in my clinic. So I'd like to acknowledge the cutaneous oncology team, Dr. Kendra, Dr. Rashegan, and also our APPs, Foom, Jessica, and Deanna. Questions and comments?
Hi, Dr. Wu.
Yes.
This is Deanna. Quick question. Could you potentially elaborate on giving us examples of when radiation treatment might be an appropriate modality for our patients?
Yes. I think radiation, for the high risk patients, is an important adjunct of the treatment for melanoma. And it's for patients who have a head melanoma in the head and neck area, and who have tumors that have broken through the outer covering of the lymph nodes, those patients definitely need to have radiation therapy to help decrease the risk of a tumor coming back locally. But oftentimes they will also need a systematic therapies to make the radiation therapy work better. So I think the radiation therapy for selected patients is a very important part of the treatment.
Hi, Dr. Wu. I don't see there's any other questions at this point. So thank you very much for your presentation. It was very insightful. And don't forget, after the symposium, we will give you a link so you can review all of this again at your own time, okay?
Yeah.
Let me try to, Dr. Wu, if you want to go ahead and share your screen.
Yeah.
Okay, and thank you very much. And
I think I already unshared it.
Okay, let me see if I can get. I'm still seeing your screen. So you still have your screen up somehow.
Let me see if I can just leave and join you.
Okay, that'll be fine. Oh, there you go. I just want to take a quick second opportunity to introduce you to Deanna. She has been a physician assistant for over 14 years. She joined our cutaneous skin oncology at the James in 2018, and we're very grateful that she came. She specializes in caring for patients of the skin cancer, including melanoma, squamous cell, basal cell, and Merkel cell. Prior to joining the James, Deanna worked in endocrinology for 11 years, caring for patients with type 1 and type 2 diabetes, hyper and hypothyroidism, and pituitary disease. She is going to be our moderator for the rest of the symposium. And I am going to turn over the mic to Deanna.
Hello, everyone. Thank you again, Foon, for the introduction. I feel very blessed to have been able to be a part of such an amazing team here at the James. And thank you, Dr. Wu, again for your presentation. And it is my privilege to introduce our next speaker, Dr. Natalie Spaccarelli, who will be giving us an update on skin exams and protection. I'd like to also remind everyone to use the Q&A feature if you have any questions along the way. Dr. Spaccarelli is a dermatologist who specializes in oncodermatology, which consists of specialty supportive dermatological care for patients who are undergoing cancer treatment. She had completed her doctorate of medicine, fellowship in cutaneous oncology, and residency, all at the University of Pennsylvania in Philadelphia. She completed her Bachelor of Arts at Dartmouth College in Hanover, New Hampshire. Her clinical and research interests are in melanoma, pigmented lesions, cutaneous lymphoma, and general dermatology. Please join me in welcoming Dr. Spaccarelli.
All right, so hopefully I won't have any more tech mishaps here. Let's see, I just share my screen, right? Okay. Share. Okay. And okay, can you see my slides? All right, great. Okay. So thank you for the introduction. Again, my name is Dr. Spaccarelli. I am an attending dermatologist with a specialty clinic at the James called the Pigmented Lesions Clinic. And this is a dermatology clinic where we do skin exams and skin surveillance for patients at higher risk for melanoma. So patients usually with a history of melanoma or with lots of atypical or dysplastic moles, or just lots of moles. And so their skin exams are kind of challenging, okay? I wanted to focus my talk today on melanoma prevention. I get a lot of patients after their first diagnosis of melanoma and they say, I feel like I got so much sun exposure when I was younger, there's probably not much I can do to prevent another lesion from happening. And I say that's absolutely not the case. And it's true that there's genetic predisposition to melanoma and if there's previous sun exposure that influences your risk. And you can't do much about the sun exposure you received previously or your genetics, but there are absolutely strategies that can help reduce further skin damage and also help you and your dermatologist pick up concerning lesions early in their development should they develop down the road. So I think the two most important components of melanoma prevention are monitoring your skin regularly and practicing good sun protection. So we'll go into both topics in depth. Before we do that, I know that Dr. Wu and others are going to speak a bit about the epidemiology of melanoma, so what the risk is for it. But I wanted to focus on kind of what the risk is for a second cutaneous melanoma, should you have one cutaneous melanoma. And I know Dr. Wu recently referred to this, but the lifetime risk of melanoma in the US general population is generally considered small. So higher in whites, okay, so 2.6% lifetime risk of melanoma, 0.1% risk lifetime over the lifetime in African Americans and 0.6% in Hispanics. The risk for a second cutaneous melanoma in those with a history of cutaneous melanoma is unsurprisingly higher than in the general population, but exactly how much higher is a bit debated. A group of experts in the field got together and made what we call consensus recommendations or analyses. And they kind of looked at all of the studies that tried to answer this question and found that about 4 to 8% of those with cutaneous melanoma develop a second cutaneous melanoma, and that this usually happens within the first 3 to 5 years following diagnosis. Another recent study that was a study of a very large database, cancer database, estimated that individuals with one cutaneous melanoma are at about 8-fold or 8 times the increased risk for getting another cutaneous melanoma when compared with the general population. So my takeaway from all of this is that, well, actually most individuals with one cutaneous melanoma will not develop a second cutaneous melanoma. They are undoubtedly at higher risk for melanoma than the general population, so good vigilance and monitoring is definitely necessary. So what is good vigilance and good monitoring? I think there's 2 parts of that. There's at-home self-skin exams, and there's regular skin exams with your dermatologist, okay? This is not only just to pick up melanomas that might happen down the road, but to also identify potential non-melanoma skin cancers like basal cell carcinomas or squamous cell carcinomas. And those are actually much more common in the general population than melanoma. The reason we think that individuals with melanoma are a higher risk for those as well is because they all share the common risk factor of lots of sun exposure, okay? And I mentioned self-skin exams, and some people get a little nervous about that. And a lot of people might say to me, oh gosh, I'm not a dermatologist, how do I know what to look for? And I think that is an excellent point, okay? But I want to emphasize that over 50% of skin cancers are actually identified by the patient and brought to the attention of the dermatologist. So your eyes are one of your best defenses against a more advanced skin cancer. So what should you look for? Dr. Wu went into this. He talked about the ABCDEs of melanoma. And, I think that they're helpful. I think they can be helpful when we're talking to other non-dermatology providers about what to look for. But I think when we're talking to higher risk people with a risk of melanoma, there's a little bit of overemphasis on this because this will help you pick up obviously concerning lesions. The ones I want to pick up and I want you to pick up are ones at the early stages that aren't so obvious, okay? So Dr. Wu mentioned this as well. E, that's the most important one, evolving. I want you to look for new or changing spots on your skin. And one of the other reasons, and kind of I alluded to this a little bit, with the ABCDEs and melanoma, it's not usually so obvious for early stage melanomas. There's a picture here of a lentigo maligna, which is a very, this particular one was in situ, so it was an early stage melanoma. Sometimes they just look like freckles on the face that may have just one or two features that are a little disconcerting to the dermatologist. And they're not necessarily picked up with the ABCDEs. You might have other spots on your face that look similar. And this picture below that is of seborrheic keratoses, which I'm sure all of us have seen before. But these often meet the ABCDE criteria and they're totally benign lesions. So it can be tough for patients to kind of figure out which one is worrisome. So again, new or changing is what I want you to focus on. I already have emphasized the E, okay? Another reason for looking for evolving is that while most melanomas develop as new spots, so moles that you've never had before, moles that you were not born with or that you didn't develop during childhood, it's thought that about 20 to 30% will develop from old moles, so moles that you have had maybe even since childhood. We typically know this is changing because some aspect of it is changing. It's growing wider, or it's getting thicker, or it's getting new colors, or it's itching, or it's bleeding. All of those are things to bring to your dermatologist's attention, okay? You might say, I'm young, okay, I'm still getting new moles, and I'm often told that they're totally benign. And that's a great point. Most often benign moles form well into your 30s, okay? This becomes less frequent in your 40s and certainly should be very infrequent in your 50s and kind of should raise a red flag with your dermatologist. I say all of this because this is kind of nuanced, and so your dermatologist should take into account your age, your risk factors, the way that particular lesion looks, and they're going to think about all that information when they're advising whether or not to biopsy the lesion. So bring new or changing to your dermatologist's attention. The self-skin check, again, kind of an intimidating idea. I advise my patients to do this once a month. And this isn't just like looking at your arms, looking at your legs, and you might say, I do that every day. Well, I really want you to set aside 20 to 30 minutes once a month to do a head to toe mole hunt, okay? You might want to use mirrors or somebody in your house to help you look at areas you can't readily look at, and really kind of make a nice dedicated time period for this. And it's important because sometimes when you're looking at your skin every single day, it becomes harder to pick up newer changing spots. So really dedicating one time for this a month can be really helpful. Another thing that can enhance your self-skin exams is using photos. Now with smartphones, you can take photos on your smartphones of your upper arms or of your back or of regions with lots of moles on them and actually use them during the exam to identify newer changing spots. You can also use the full body photography that some dermatologists might be able to provide you with, which we'll talk about in a few slides. One app that I really like for my patients to use if they can, unfortunately, it's only available on an iPhone, is this Mole Mapper app. It's out of OHSU on the West Coast, and it's very neat. It allows you to take photographs of regions of your skin, up close photographs of spots on your skin. You can even measure them out. And you can either take photos over time so you can compare the photos, or you can just use the photos on the app when you do your self-skin exams. It's a really elegant and easy to use app, and it's free. So if you're interested, you should check it out. Is there any way I can go? Hold on one second. Sorry, a little. Okay. So you might be asking how frequently you should get skin exams with your dermatologist, okay? There's a lot of debate about this, okay? Recommendations vary, okay? But I generally kind of follow the following guidelines, which were released by a consensus group. I tend to err on the more frequent advice, okay? But for melanoma in situ with stage 0 melanoma, it's advised that you get a skin exam at least every 6 to 12 months for the first 1 to 2 years after diagnosis. I tend to do every 6 months for 2 years at least. For higher stages, it's obviously more frequent. For the highest stages, it's advised every 3 to 6 months for the first 2 years, and then sort of staggering to every 6 months for 3 to 5 years, and then at least annually. So just to give you an idea, there's a huge range, okay? I think there is such a thing as over-examining and too frequent exams, because it can burn patients out and make them sort of less likely to want to go to their follow-up appointments because they're happening too frequently. So if you feel like that's happening, that's definitely something to talk about with your dermatologist. You can say, hey, can I cut down a little bit? We haven't found something concerning in a long time. It's a reasonable topic to raise. So what should your dermatologist be using during your skin exams if you're a higher risk patient? Right here are photographs of what are called dermatoscopes. Okay, you've probably seen your dermatologist use these during your exam. And they're really nifty little devices. A lot of people think they're just glorified magnifying glasses, which they do magnify the skin lesions when you look at the skin lesions through the scopes. But they also use polarized and non-polarized light to allow the viewer to visualize structures in the skin or in the lesion that you actually can't readily see with your naked eye. So we're seeing things and patterns through these dermatoscopes that we can't actually see just with our naked eye. So they're immensely useful. Training on dermoscopy takes time. So all dermatologists now should be trained on this modality during residency. It also takes practice, okay? Just to give you an idea, so these are patterns that we see on dermoscopy when we look at the scope. These are obviously illustrations, but they kind of give you an idea of what we're looking for. The top row there are common benign patterns associated with benign moles or nevi. So when we see these patterns, we're generally reassured. The bottom two lines are patterns that we tend to see with worrisome lesions or lesions that might be melanoma. And so when we see these patterns, we generally want to biopsy them. To give you an idea, this is about 1/5 of the patterns that we need to recognize when we look through the dermatoscopes. So it takes an immense amount of expertise to get good at this. And again, a lot of practice too. I have some patients ask me if they should buy their own dermatoscopes, and I would advise against buying your own dermatoscopes and trying to interpret these images yourself. It's very difficult. But just to get you to understand that this takes a lot of practice, and your dermatologist really should be devoted to going back to the literature and to kind of constantly brushing up on dermoscopy, because it can be helpful, but in inexperienced hands, sometimes it may lead to over biopsying or under biopsying because they're not correctly identifying certain structures. It's not a perfect science, okay? Your dermatologist might say, hey, I'm really worried about this because the way it looks on my dermatoscope, and it may come back benign. But it's just a very useful tool to use in conjunction, with the naked eye. I've referred to this full body photography. What is that? Full body photography is kind of professional photos of every area of skin that you have, okay? And it can be really, really useful to use during your derm exam in the office. I got these two photos here of these kind of intimidating looking machines. Some places, though I'd say this is pretty rare now, actually have a live medical photographer who will take pictures and provide you with like physical pictures of your skin. But the more common approach at this point is to actually, for the institution to purchase these systems that are automated and can take photos. The one on the left is the Canfield IntelliStudio, and that's the one that we have. The one on the right is also Canfield. It's called the Vectra. It's kind of slightly scary looking. It's humongous. It's actually probably only available at 10 locations in the United States. It's very expensive and it's very large. So it's hard for, not all locations can even offer this just because of the size limitations. It will create a 3D avatar of your body, which I've used it before. I'm not totally convinced that 3-dimensional avatars are more useful to monitor your skin than 2-dimensional photos, which is what we use, but it's an interesting technology. Who gets full body photography? I actually don't offer it to all my patients, even if they have a history of melanoma. I try to identify the ones that are likely to get the most use out of it. So probably only 40% of my high-risk patients have it. I look for patients who have challenging skin exams. And that I usually define as patients who have lots of moles or lots of kind of atypical appearing, or maybe not a lot of moles, but kind of atypical appearing moles. So those are the patients I generally ask to do this. It can also be helpful for patients who may not have a challenging skin exam, but want it, who find it reassuring to use at home, who find it reassuring that the dermatologist is using it during their exam. So I always welcome my willing patients, the photography if they would like it. Okay. Downside sometimes of doing it when you're quite young, like, in your 20s or 30s, is you may have to repeat it again because you are getting those new moles. Why get it if it's recommended to you? I really think it enhances the exam quality I can do and other dermatologists can do in the office. Correct use of this really is toggling constantly between the photos and the skin. I match up every single lesion I see in the photos to every lesion on the skin to see if I can pick up subtle, new or changing spots. Some people use it, they'll look at the skin, they'll identify, hey, that one looks a little odd, I'm going to see if it was there in the photographs. That's not wrong, but it's probably not the most useful way to use the photos. Doing it by toggling constantly is really time consuming. And so that's sometimes not an option for everyone. But I find that I pick up things that I wouldn't readily pick up by doing it that way. It's also shown to reduce the number of biopsies over time that patients get. In general, if you've had melanoma, your providers, believe it or not, are a little more nervous about the spots on your skin. And so they may have a lower threshold in their minds to take a spot off to biopsy. But when they can look back at the photographs and say, oh, this has been there for 3 years, it doesn't look any different. That's just another reassurance they can give you and themselves and maybe get you out of a biopsy that you didn't necessarily need. So just a few words about atypical or dysplastic moles. You're going to find that if people do biopsies after your initial melanoma diagnosis, that they're often coming back atypical or dysplastic. And what does that kind of mean? I find that the majority of spots that I biopsy are called dysplastic or atypical. And what really matters is the degree of atypia. I'd say most pathologists now kind of note the degree of atypia, though there's some variability. For us, what matters is whether it's mild, moderately, or severely atypical. Mildly atypical moles are generally benign, though they're called atypicals, and they don't typically need to come out. Severely atypical moles are concerning. They could transition into melanoma, and so I generally excise those afterwards with the same margins that I excise melanoma in situs. Moderately atypical moles is a bit of a gray zone, okay? I think a lot of pigmented lesions experts don't typically go after these after they've been biopsied, because there's a fair amount of evidence to suggest that they never turn into something concerning or rarely so. But your dermatologist should know the reading pathologist really well. I know my pathologist. I know if they call something moderate and don't tell me to take it out, I can typically leave it in the skin and monitor it over time. But this varies from provider to provider, but I think it's useful to kind of understand what atypical or dysplastic means. Okay. And if you're finding that your provider is taking a lot off after the biopsies, maybe an issue to raise, say, hey, what's the chances that this is going to turn into something really bad? Is there any way we can monitor it? And you may be surprised that that's more of a conversation, a back and forth than you thought it would be. So just so you're aware. All right, shifting gears, sun protection. This probably seems a bit obvious to you, but using sunscreen is really important, but using it the correct way is probably the most important. I generally advise people to use at least SPF 30. If you're applying it every 2 hours as advised outside and you're still getting a little pink or tan, that may be an indication to kick up the SPF of the sunscreen higher, okay? I like them to be broad spectrum, so UVA and UVB protected, and water resistant, because sweat and water can dilute the efficacy of sunscreen. Also note that if you're going in and out of the water, you may need to reapply the sunscreen more frequently than every 2 hours. Avoiding the sun during peak hours, so from 10 a.m. to 2 p.m. can be very helpful. And wearing hats and sun protective, usually let's say like UPF 50 clothing, can be helpful as well. You may have heard in the news recently some concerning words about sunscreen. So I want to go over that very briefly, all right? Because the wording surrounding all this is confusing for most people. So in 2019, the FDA issued what is called a proposed rule, okay? They kind of were looking at ingredients and the evidence behind sunscreen ingredients, specifically the safety of those ingredients. They identified 2 ingredients as GRACE, okay, are generally recognized as safe and effective. And those were the physical blockers, zinc oxide and titanium dioxide. They identified 2 ingredients that aren't even available in legal US sunscreens as not GRACE, so you don't really need to worry about those 2. They requested more information about the following ingredients you see listed there that are in lots of sunscreens in the United States. And so many people became concerned, if they're requesting more information, what does this mean? Does this mean that it's not safe? To me, the take-home points of this obviously is that evidence is needed. They want more studies, but the FDA did not deem these ingredients unsafe and has not asked the public to stop using them. If the proposed rule makes you a bit uneasy, then you should look for sunscreens that contain the active ingredients. So when you turn over the sunscreen, it'll say active ingredients that are just physical blockers, zinc oxide or titanium dioxide. But again, we don't think that these are unsafe from this proposed rule. They're requesting more information, but I understand that all of this verbiage can be kind of confusing. So to summarize my strategies for melanoma prevention, examine your own skin thoroughly on a monthly basis, and photos may be very helpful. Bring any new or changing lesion to the attention of your dermatologist or your surgical oncologist or your oncologist, okay? Receive regular skin exams with your dermatologist. Practice high quality sun protection, so sunscreen, sun protective clothing, and trying to avoid the sun during peak hours. And thanks so much for your time.
Thank you, Dr. Speccarelli. We really appreciate your time and your presentation. We do have one question regarding the total body photography option. Do you have a recommendation of how often it would be helpful to have that performed on patients? And is it covered by insurance at this point in time?
So most pigmented lesion centers, so places that have these dedicated clinics, do run this through your insurance. And we actually do that now at Ohio State. And we are finding that for high-risk patients with medical histories of melanoma or with dysplastic nevi, do have it covered by their insurance, okay? If it is not covered by their insurance, generally we charge, I can't speak to other institutions, we charge about $160 if it's not covered at all. Okay, but usually what I found is that if institutions or people that have the photography aren't running it by insurance, usually it's between $150 and $250 for the process. And in terms of frequency of repeating, it really depends. If your skin exam is changing a lot, if you're getting new moles, or if you're getting a lot of things taken off, okay, you may need to repeat it in as short as 5 years. But if neither of those things is the case, then you may be good to go for 10 years or even more. It's just up to your provider usually.
Okay, thank you very much for your time. We appreciate you. Next, we have Dr. Lana Putrakal joining us to discuss Mohs micrographic surgery. Could you try to unshare your screen as well, Dr. Speccarelli?
Sure. Let me.
Dr. Putrakal is a board certified dermatologist and fellowship trained Mohs surgeon who specializes in the highly precise Mohs technique to remove skin cancers, including basal cell carcinoma, squamous cell carcinoma, and melanoma in situ. Dr. Putrakal also leads the hospital-based Mohs surgery program at the James. Her additional special interests include management of skin cancers in transplant patients and in other complex skin tumors. Please join me in welcoming Dr. Putrical.
Hi, thank you, Deanna, and good morning. I just want to see what's easiest here. I am going to go ahead and share my screen. Please let me know. Here.
Do you need help?
I'm good. Let me just make sure here. Is everyone seeing my presentation? Okay, perfect. All right, again, good morning. I'm Lana Putrical, and I am the Mohs surgeon at the James, working at the Martha Morehouse Tower on the 4th floor. And I'm here this morning to talk to you about Mohs micrographic surgery and surgical management of melanoma in situ with 100% margin control. Now, some of you may have already heard about Mohs surgery since we use it for the most common skin cancers in the world, basal cell carcinoma and squamous cell carcinoma. And I'm here today to talk to you about the application for melanoma in situ. So we've all seen these irregular brown spots on our family members, on friends, maybe on ourselves. And as you can see here, we commonly see them on very sun-exposed areas. This is behind an ear, in front of an ear, on a cheek. Here is on the ball of the cheek. This one is on a forehead here. And then this one is on the other cheek there. And as you can see, all in sun-exposed areas, these sort of brown and sometimes brown, black, pink blotches that can sort of stand out as that ugly duckling on someone's face or actually anywhere on the body. And these are all examples of melanoma in situ. As I said before, you commonly see these in highly sun-exposed areas. So if you take a look at all these pictures, what you see in common with all of them is the background skin is generally aged skin, lots of freckling or other signs of sun damage. So what we're going to go through today, our topics are melanoma in situ. What exactly is it? The features of Mohs micrographic surgery. How does Mohs differ from standard excision or other types of surgery? And what are the technical aspects of Mohs, or what will your day be like when you come in to see Mohs? To do Mohs, I'm sorry. So first off, what is melanoma in situ? I like to communicate in terms of food. I think it's sort of a universal language. So when I talk to my patients, I tell them to think about the layers of their skin, like the layers of a cake. And so this is a schematic of the layers of the human skin. The top, the very, very top layer or outermost layer is the epidermis. The second layer is the dermis. And then underneath that, we have the fat. And again, I like to talk using the universal language of food, and I think it's just easiest to understand. So if you think about melanoma in situ, we think about it as sitting in the frosting of the cake of your skin. So if you think about the layers of your skin, again, like the layers of a cake, the melanoma in situ type skin cancer is in that frosting of the cake. It hasn't yet dipped down into the cake where it can cause more invasive disease. And we think of this as a pre-melanoma or a stage 0 melanoma. And again, here's another schematic just to show what I'm talking about. On the left here, you have normal skin, and your melanocytes or mole cells normally reside in that epidermis or that frosting of the cake layer. When they start to grow out of control or become malignant cells, if it stays in the frosting of the cake or that epidermal layer, it's melanoma in situ. And then of course, the next step is when it becomes invasive, dips down into the cake of your skin and becomes invasive melanoma. Today, we'll be talking about melanoma in situ. And what are the key features of Mohs micrographic surgery? So those of us who perform Mohs surgery are actually specially trained to fulfill 3 roles. We are the surgeons who remove the cancerous tissue. We are actually the pathologist as well who analyzes that specimen that we take back. And then finally, we are the surgeon who does the reconstruction or closes that wound before you go home. And what are the advantages of having Mohs surgery? Well, as I said before, we do all that treatment generally happens in a single visit in outpatient surgery. We do it under local anesthesia to minimize the dangers that you could potentially undergo with general anesthesia. And all that lab work and examination of the lab specimen is done on site, usually in the same hallway or in the same office. We have very precise results. We examine 100% of the tissue edges, and that's the side edges and the bottom edges of that tissue. By doing this, we can actually spare as much normal and healthy tissue as possible, and subsequently, this leaves the smallest scar possible. Mohs surgery offers the highest cure rates for non-melanoma skin cancers that have not been treated before, and this is up to a 99% cure rate. And for melanoma in situ, it has been reported that there is no difference between wide excision and Mohs micrographic surgery for the treatment of this skin cancer. Now, how does Mohs surgery differ from other types of surgery? And so this is sort of a schematic comparing the two types of surgery, the Mohs technique versus conventional or standard excision or a wide excision. So with the Mohs surgery, we cut off a piece of tissue just around the actual skin cancer, and it's a disc of skin that almost looks like a Reese's Pieces peanut butter cup. I like to use food again in my examples. I think it's just the easiest to understand. And what we do is we flatten out that tissue and we slice it from the bottom. And it's almost as if you think about that Reese's Pieces peanut butter cup wrapper that you flatten out. And those are the specimens that we take. And so we actually get 100% of that side edge, and you'll see the fat in the middle, we get 100% of that bottom edge. And so with the Mohs technique, you actually examine 100% of the margin. With conventional or standard excision, when they take that skin, they actually cut it like a loaf of bread. It's sliced like a loaf of bread, and in that way, less than 1% of the margin is examined. And again, just to show you the example here, we've got our Reese's Pieces peanut butter cup in Mohs surgery. We flatten out that wrapper, and what we have now is 100% of the side edge and 100% of the bottom edges. And we take several of these layers. And again, conventional surgery or wide excision, they slice it like a loaf of bread. And what they're actually examining is the spaces in between the bread. The loaf itself doesn't get examined. And just back to our picture here, just to make sure, Mohs technique, we're cutting from the bottom, conventional excision, they're taking slices like a loaf of bread. And don't get me wrong, there are many, many indications where you would prefer the method of standard excision. Dr. Contreras will go over that. I just wanted to give you an idea of the difference between the two. And what are the technical aspects of Mohs surgery? What will your day be like when you come in to see me? Well, first things first, let's make sure I've got the right spot. You and I are going to make sure that we agree on the spot. We'll get you numbed up, and then we'll remove that specimen. And like I said before, because we examine 100% of that margin, after we identify the specimen, we take a teeny tiny margin right around it so that the defect that you're left with is not that much bigger than the original spot. We make a map of where we've taken the skin cancer from your skin. So I know exactly where I need to go back in to get more skin if I see any skin cancer on the edges. We actually paint your tissue to make sure that our map is precise. And again, we take it back for that Mohs processing of that Reese's Pieces peanut butter cup tissue, flatten it out, and then we cut it from the bottom so that we can examine all of the margin. And then that is me and one of my chief residents, Dr. Corman. We take it back and look at it under the microscope, and here he is learning how to identify basal cell carcinoma. And then from your perspective, what happens is once we're all done getting that skin cancer out, we immediately stitch you back up. We do the reconstructive surgery. And several weeks later, the goal is that you don't have to worry about that skin cancer anymore and that that scar is minimal. Take home points. Melanoma in situ occurs most commonly in sun-exposed areas of the body and is considered stage T0 melanoma, or that frosting of the cake melanoma. The primary goals of Mohs surgery are 100% removal of that tumor or cure of the tumor, maximal preservation of function on places like your ears, nose, eyelids, lips, and of course, maximal preservation of cosmesis or cosmetic outcome and cost effectiveness. And finally, Mohs micrographic surgery is a precise technique performed by fellowship trained physicians and offers high cure rates with the smallest scars possible. This is my hometown of Phoenix, Arizona. Thank you for listening to me this morning. And please feel free to reach out to me if I can't get to your answers today or your questions today. Thank you.
Thank you, Dr. Putrapal, for your time. We really appreciate it. I'd also like to remind everyone to, if you have any questions along the way, you can use the Q&A section at the bottom of the screen. And I know we're running about 5 minutes behind, but we will keep moving forward. And if needed, we may be able to skip the break in the near future. But we will shift to our next presentation. We have Dr. Brianna Archambault. Dr. Archambault is a specialty practice pharmacist with a focus on oncology pharmacy. She started working at the James Cancer Center in July of 2019. She has spent her time rotating between inpatient medical oncology services in the James Cancer Center and in the outpatient melanoma and neuroendocrine clinics. Prior to coming to OSU, Brianna completed an oncology-focused pharmacy residency at Hermanos Cancer Center in Detroit, Michigan. Please join me in welcoming Dr. Archambault.
Oh, hi, everyone. Sorry, I forgot to unmute myself. I'll go ahead and share my screen and we'll get talking. So as a pharmacist, kind of what I do is the drugs, right? So the systemic treatments that patients receive for their melanoma. And so the focus today is really going to be on those melanoma drug therapies. And we have basically 3 types of therapies that we use, different categories. And so for today, I want us to just kind of understand the difference between our cytotoxic chemotherapy and some of those associated side effects, as well as looking at immunotherapy and side effects associated with that. And then lastly, looking at our targeted therapies and understanding some of the side effects and how patients would take those medications. So the first thing I really want to discuss is kind of these 3 distinct types of drug treatments that we use. So we use kind of a broad category. We use chemotherapy, immunotherapy, as well as targeted therapy. And although all of these are things that we use to treat melanoma, they are distinctly different in how they work, and then therefore also different in some of the side effects that patients can expect. So first off, we have chemotherapy. This is the type of therapy that patients really think of when you think of cancer and you think of treatment. Chemotherapy is the first thing that people think of. This is that traditional treatment. And the way that chemotherapy really works is just by going after cells that are currently in the cell cycle, meaning they're kind of in that process of growing. And so the common drugs that we use in melanoma are paclitaxel, temozolomide, dacarbazine, and carboplatin. Next, we have our immunotherapy. And this works different in that it actually uses the immune system to help fight the cancer. Currently, there are a handful of different medications that we use, such as nivolumab, ipilimumab, pembrolizumab, and atezolizumab. We also do an injectable drug called T-VEC, but we won't be talking about that as in depth today. And lastly, we have our targeted therapy. And the way that targeted therapy works is that it's going to target those specific mutations that we can find in cancer cells. And so for this, we have a combination of either dabrafenib with trametinib, vemurafenib with cobimetinib, or encorafenib with binimetinib. So the first type of drug treatment I want to discuss is the chemotherapy, because this is really kind of those traditional medications. It's the type of treatment that we've been using for cancer for a very long time. And it works a little bit differently. So when we think of chemotherapy, it is that traditional anti-cancer treatment. And the way that it works is it's going to target the cell cycle. So if you think of your body, it's made up of all these different cells. And these cells are those building blocks that make you and make your different organs in your skin. Well, in order for these cells to function, they do have a life cycle. So they have to go through this process of getting prepared to replicate themselves and then going through replication and to form new cells. With cancer cells, those cells grow much faster than normal cells. And so the way that chemotherapy works is it's going to target all the cells that are going through this process of growing. So if you kind of remember back to any of your biology classes, maybe in high school or college, you may have learned a little bit about the cell cycle. There are 5 stages within the cell cycle, and the cell cycle is normal in both your normal cells and cancer cells. It's just that cancer cells are much more aggressive and more so in this cell cycle. So we have our interphase, which consists of G0, G1, S phase, and G2. And essentially this interphase, the purpose is to copy the DNA in those cells so that the cell can split into 2. Then we have mitosis, and this is the process in which that DNA has been replicated. They're on opposite sides of the cell now, and now they split. And they're 2 cells instead of that, just 1. So the first chemotherapy agent we're going to talk about is dacarbazine. Now, we don't commonly use this in clinic anymore, but this is a drug that we refer to as an alkylating agent. The way that it's going to work is it's just going to damage that DNA. And so if a cell DNA cannot be copied because of its damage, then the cell is going to die. So this is a 45-minute IV infusion that's given every 3 weeks. And some of the really common side effects include low white blood cells, can cause nausea and vomiting. And because of that, you will often be given pre-medications to prevent that nausea. It can also cause some neuropathy as well as sun sensitivity. Our next chemotherapy drug is temozolomide. And this we use a little bit more commonly. It is essentially the same drug as dacarbazine. They both work in the very same way. It's just temozolomide can be given as an oral medication. But this is what we also refer to as an alkylating agent. So it's going to cause damage to that DNA. When we can't copy the DNA, the cell is damaged and it cannot grow. So this drug is an oral chemotherapy drug. It is taken by mouth on days 1 to 5 of a 28-day treatment cycle. So essentially 5 days every month, a patient will be taking temozolomide. We do recommend to take this on an empty stomach at bedtime. And then prior to taking the temozolomide, you want to take a nausea medication known as ondansetron about 30 to 60 more minutes before it, because that will help to decrease the nausea. That's also why we recommend taking it at bedtime, because this medication can cause some nausea. That way patients can kind of sleep through the worst of feeling that nausea. In terms of side effects, it's similar to dacarbazine, so it can cause low blood counts. So that would be your white blood cells, your red blood cells, and your platelets. Now, when your white blood cells are low, that is going to increase that risk of infection. And when your red blood cells are low, that essentially causes anemia. And this is really what makes patients start to feel more fatigued and just overall kind of a general unwell feeling when they are taking chemotherapy. And then lastly, it affects your platelets. And these cells are very important for making blood clots. And so patients have an increased risk of bleeding and bruising when they are on chemotherapy when their platelets drop. This can cause some nausea and vomiting. And so, like I said, we recommend to take it at bedtime and to take ondansetron before it. It can also cause headaches. So sometimes we may recommend to take something like acetaminophen or ibuprofen before the dose if headaches are a problem. It can cause either constipation or diarrhea, but I would commonly say, in my experience, we've seen constipation a little bit more. And then lastly, just fatigue. So in general, chemotherapy kind of can really wipe patients out. So there just may be that general feeling of just a little bit more tired, less energy. Our next chemotherapy drug that we use commonly in melanoma is our protein-bound paclitaxel. So the way that this works is it's a microtubule inhibitor. So during that mitosis phase, when those two cells are splitting, the microtubules kind of pull all the DNA apart so that the cell can become two. And once we stop those microtubules, it can't pull those two cells apart to make two new cells. And therefore, it's going to cause cell death during that process of mitosis. So this drug is given as a 30-minute IV infusion, and it's given every 3 weeks. In terms of side effects, it can also cause low blood counts. It can cause some muscle aches and pains, even some numbness and tingling, which we refer to commonly as neuropathy. And then it can cause hair loss and thinning, and that typically occurs about a week to a week and a half after receiving the first dose. And then our last combination of chemotherapy that we use in melanoma is carboplatin in combination with paclitaxel. So carboplatin is considered a platinum agent. So this is going to damage the DNA of the cell and cause cell death. And then we use it in combination with the paclitaxel, which is a microtubule inhibitor. So they both target the cell cycle, but just a little bit differently. So the paclitaxel is actually a 3-hour infusion. And that's different from the protein-bound paclitaxel because there's much more of a risk of an infusion reaction. And so we do have to give it over a longer period of time than the protein-bound version. And then the carboplatin is a 1-hour infusion. For this, the two infusions wouldn't be given at the same time. You would get paclitaxel first and then carboplatin afterwards. So it'd be 4 hours worth of infusion, and it's given every 3 weeks. In terms of side effects, there can definitely be low blood counts, which is a very common side effect of chemo in general. It can cause hypersensitivity reactions. So essentially what that means is it's an allergic reaction to the medications. So that could be burning or itching at the infusion site, redness, swelling. Patients in worst case can have shortness of breath due to these medications. And both carboplatin and paclitaxel can cause hypersensitivity. Numbness and tingling are common with both of these agents, as well as hair loss and hair thinning. And then lastly, fatigue is a common side effect of these as well. They can cause increased risk of nausea, vomiting as well, which is not listed on this slide, but patients will receive some pre-medications beforehand to prevent both nausea as well as prevent that hypersensitivity reaction. And then patients will also a lot of times have a prescription for something at home for as needed, such as a drug called prochlorperazine. In the instance, they would have nausea after they leave from the infusion. So that kind of gives us a little segue into immunotherapy, which is really one of the main backbones of treatment in melanoma now. They've really found that the immune system is very involved in preventing cancers, and especially in melanoma, we really know that getting the immune system to help fight the cancer has been shown to be very effective. So I always like to just think about, what is the immune system? What does it do for us? And why is this important for fighting cancer? So your immune system is really a complex system of defense. There's a lot of players in your immune systems that work in a lot of different ways. But the number one role of the immune system is to keep everything balanced and defend you against pathogens. And so what pathogens are those cells or things that are not supposed to be there. So most of the time we really think of pathogens as being a virus or a bacteria, but really any abnormal cell, such as cancer cells, are seen by the immune system and the immune system gets rid of it. Now, what happens with cancer, and specifically melanoma, is sometimes the immune system is no longer able to see those cells in the same way, and it can't act against them as strongly. And so that's why we've seen immunotherapy be so effective, because it really allows the immune system to do its job much better. When we think of the immune system, there are a lot of players, but we essentially have two distinct systems that work hand in hand to protect you. So you have your innate immune system, which is very non-specific. And so those are things like your skin. Most people don't think of that, but your skin is part of your immune system to protect you against different pathogens, and your white blood cells. So these are that really quick response that responds to pathogens quickly to get rid of them. Now we also have the adaptive immune system, and this is much more specific. So all these different cells in your body have different proteins and receptors on them that really help to identify what they are. And your immune system is able to see these proteins and these receptors to identify them. What the adaptive immune system is able to do is it can see the proteins on these cells and recognize whether that is a pathogen or not a pathogen. And so we have our B cells and our T cells that are involved in this process. When they see those receptors or those antigens on the cells, they can say, hey, that is not supposed to be here. And then they can start to act against it. So your B cells are involved in making antibodies, whereas your T cells kind of have a couple different functions. One, your T cells can help to regulate how your immune system functions, but you also have what we refer to as toxic T cells. And those T cells are the ones who really get in there and can kill those cells when they detect that, those are cells that aren't supposed to be there. So types of immunotherapy, we have a couple different types. The mainstay in melanoma are what we refer to as our immune checkpoint inhibitors. So we have our programmed death receptor inhibitors and our cytotoxic lymphocyte-associated antigen 4 inhibitors. I know those are really big words. Most of the time it's just referred to as PD-1 or CTLA-4. And what I wanted you to understand here is that we just have some very different ways that we can kind of target these cancer cells with immunotherapy. The overarching mechanism of these drugs is to use your immune system to fight the cancer. What cancer can do is it can, in a way, hide from those T cells, and it kind of turns the T cells off against them. So what checkpoint inhibitors can do is they can stop that cancer from hiding from the T cells. So our first type is the CTLA-4. So with this diagram, I know it's kind of a lot going on, but what I really want to show is in your T cell, you can see kind of up top here, this is the T cell, and inside of it is the CTLA-4 receptor. This would be your antigen cell that presents to say, hey, T cell, turn on. So when the T cell is like this, it's turned on. Now, sometimes when this receptor comes to the surface of the T cell and it binds to this CD80, the T cell is turned off. So even though it is connected to this cell, it says, hey, this is not something that I need to attack, and it shuts off. And so if this is a cancer cell here and you have this interaction, then the T cell cannot act against it. So what our CTLA4 inhibitor is going to do is it's going to bind to this CTLA4 on the T cell, so it can't have that interaction. So now this can see this cell and be turned on against it. In a similar way, we have our PD-1 inhibitors, and so they also work in a very similar way. So if you see here, you have your T cell, and then you have your PD-1 on the T cell. It's going to bind to this PD-L1 on the tumor cell, and when this happens, it basically turns this T cell off. The T cell sees this and it goes, okay, I don't need to act against this cell, and it shuts off. And so these tumor cells have a lot of this PD-L1 on it. So it kind of tricks the immune system into not being able to see it as a cell that shouldn't be there. So what our therapies do is we have our anti-PD-1 therapies and our anti-PD-L1 therapies. They're going to bind to these two things right here. So now the T cell can see this through this interaction, and it can actually work against that cancer cell now. So I know that's kind of a lot to think about, and I tried to use the pictures to demonstrate this, but essentially at the end of the day, what these therapies are going to do is it's going to turn off that interaction so your T cells can see cancer and they can get rid of that cancer for you. And so for our immunotherapy, our CTLA4 inhibitor is a drug called ipilimumab. That is a 90-minute IV infusion, and it's given with or without nivolumab. And so as you know, CTLA and the PD-1 are different. I think of them as kind of like cousin drugs. So they're related, but they're a little bit different, right? So we can use those together to work a little bit stronger against the cancer. Then we have our PD-1 inhibitors, nivolumab, which is a 30-minute infusion that can be given with or without ipilimumab. And then pembrolizumab, which is a 30-minute IV infusion. And then lastly, we have atezolizumab, and that is a 60-minute IV infusion. And when that is given, it's usually given in combination with targeted therapy. Now, immunotherapy, I always like to point out, it is very different than traditional chemotherapy. We talked about how chemotherapy targets the cells that are growing really fast, whereas immunotherapy opens up the eyes of the immune system. And so now those T cells can work against the cancer. So they work very differently. And so therefore their side effects can be very different. So two of the really common side effects would be fatigue. So patients may just feel a little less energy when they receive immunotherapy. You can have an infusion reaction, although it's pretty uncommon, and even sometimes flu-like symptoms. So you may feel a little bit more achy, maybe even a small low-grade fever. But in general, most of our patients do very well with immunotherapy and don't have a lot of side effects. Now, the side effects that are much less common but more severe are what we refer to as our immune-related side effects. So these immune-related side effects occur because we kind of open the eyes of the immune system, right? We really got those T cells going. Sometimes they get a little bit too aggressive. And instead of just attacking your cancer cells, those T cells can start to attack your normal cells. When your immune system goes after normal, healthy cells, it can cause inflammation reactions, and these can lead to pretty significant issues pretty much anywhere in the body. The four most common sites we see this immune-related side effect and this increase in inflammation would be one, your liver. So while patients are on immunotherapy, we get liver function tests while they're taking it. But if a patient is starting to feel more pain in their abdomen, they're starting to notice their belly getting bigger, a little bit fuller, any yellowing of the skin or eyes, those could be signs that maybe something is wrong with the liver. We can also see inflammation in the colon. What happens here is pretty severe diarrhea. And so when we say diarrhea, we don't just mean watery, runny bowel movements. What we want to know is a change in baseline. So if you have one good solid bowel movement every day and you start immunotherapy and you have 5 bowel movements every day, solid or liquid, that's concerning, right? That's not normal, and it could be a side effect of the treatment, and our team would want to know. We can also see skin inflammation, so that presents as a rash. It can happen anywhere on the body. It could be red, it could be raised. And then lastly, it can affect some of your hormones, such as your thyroid hormone or some of your adrenal hormones. When this happens, patients can feel really tired, really out of it. Their nails could get more brittle, hair thinning, dizziness, just overall fatigue. If you're starting to feel those things, let the doctor know, because that could be a sign that maybe some of those hormones are changing and they need to do some additional lab tests. Now, at Ohio State, part of our standard is to check the thyroid numbers before every treatment. And so we keep a really good eye on that to make sure that there's no problems. Now, with these immune-related side effects, the risk of them depends on the type of immunotherapy. So patients who receive combination immunotherapy with ipilimumab and nivolumab have a much more increased risk of having immune-related side effects versus someone who's just on a PD-1 inhibitor by itself, like nivolumab by itself or pembrolizumab by itself. And then lastly, we're going to talk about some of our targeted therapies. So targeted therapies are really interesting in that they capitalize on the mutations that we see in these cancer cells. We've gotten really, really good at doing DNA testing on cancer cells to see if there's any special mutations. Specifically in melanoma, what we look for are what we refer to as BRAF mutations. These can occur in about 40 to 50% of patients. Most commonly, it's going to be a BRAF V600E or a V600K mutation. When a patient has these BRAF mutations, what it does is it's a mutation that leads to abnormal cell growth. And so if a patient has a BRAF mutation, we can use a BRAF inhibitor in order to target that mutation to shut it off so that the cells don't keep growing. So we have our BRAF inhibitors, and we use those in combination with a drug called our MEK inhibitors. So we have dabrafenib, which is given with trametinib, or vemurafenib with cobimetinib, and then lastly, encorafenib, which is given with binimetinib. So how do these work? What does it mean to have a BRAF mutation? So this diagram kind of shows what's going on inside of the cell. So I think of this kind of like a telephone tree. So if you think with a telephone tree, the purpose, right, is to relay a message to people within that group. And so it's similar within this cell. So in order for your cells to grow, they have to be told to do it. They don't just decide on their own. And so what happens with this pathway is you have this MAPK pathway. And what happens is there's this step in the pathway called BRAF. And when you have a mutation there, it just keeps firing. So it keeps sending signals all the way down. The signals just keep coming. So it'd be like that one person in your telephone tree who just keeps calling everyone and just keeps going hard, hard, hard. And so what happens is when you send all these signals, it's going to lead to cell growth. So these signals are going to tell the cell, you need to make the DNA, you need to replicate it, and then you're going to grow. And so what we do with our BRAF inhibitors is we block this signal. So it's going to stop that BRAF mutation from sending the signal to tell the cell to grow. And then you can see here that MEK is just below BRAF, which is why we use them together, because we want to block two parts of this pathway to prevent those signals from going to tell the cell to stop. So our first combination, we have dabrafenib and trametinib. These are oral medications, And so the dabrafenib would be a dose of 150 milligrams 2 times a day, and trametinib would be 2 milligrams once a day. Both of these medications do have to be taken on an empty stomach. And what's interesting about the trametinib is you actually would have to restore this in the refrigerator. So it can't be stored at room temperature. The other thing is in the trametinib bottle, you have to keep it in that same bottle it comes in, and there's going to be a little packet in it. So like when you get shoes, they put those little like packets in there to keep them fresh. Same thing with the trametinib. There's going to be a little desiccant packet in there in the bottle to keep that drug fresh and stable. And so you want to keep that desiccant in there. I know whenever I open something up, I just throw that out. For the trametinib, we just keep it in there. In terms of the side effects, one of the really common side effects with this combination is fever. So you can have a drug-induced fever, and that can cause some pretty serious fever and chills. That usually happens about 2 weeks or so after starting therapy. If it does happen, that is an instance to definitely call the team to let them know, because a fever can kind of give us an idea of maybe it's a side effect of the drug, or fevers are also common when someone has an infection. So we want to know if a fever does occur. Sometimes we can have the patient take acetaminophen or ibuprofen prior to their dose, and that helps with the fever. It can cause abnormal heartbeat. And so it's very common to get what we call an EKG to assess how the heart rhythm is, as well as an echocardiogram, which is going to tell us how well the heart is pumping. So there's some extra tests that we may get before a patient starts these treatments. They're also associated with a rash, as well as it can cause some nausea and vision changes. Next, we have our vemurafenib and our cobimetinib. And the vemurafenib is 960 milligrams twice daily, whereas the cobimetinib is 60 milligrams once a day on days 1 to 21 of a 28-day cycle. So 3 weeks on, 1 week off. These medications can be taken with or without food. And some of the common side effects include rash. But in general, these drugs are very associated with what we call photosensitivity. So when a patient takes these medications, there is an increased risk of having a sunburn. Even to the, let's say you're driving to your appointment and it's a really sunny day outside and your arm is hanging out the window or right by that window, you could get a sunburn by just your arm being within that window. So we really stress making sure that appropriate sunscreen, appropriate clothing, even wearing chapstick that it has SPF protection on it, because you can also get a sunburn on your lips. We don't usually think about that, but it is very common with this combination. These drugs can also cause an abnormal heartbeat. So we would get an EKG and an echo. You could see some joint and muscle pain, some vision changes, fever, and even diarrhea can be common. And then our last combination is encorafenib and binimetinib. So the encorafenib is going to be 450 milligrams once a day, and the binimetinib is 45 milligrams twice a day. And so these can also be taken with or without food. And the side effects are pretty similar to the other medications that we talked about. They can cause some fatigue, some nausea, abdominal pain. Fever is a risk with this combination as well, and vision changes. So we talked a little bit about some of the monitoring we have to do. When patients are on targeted therapy, we look at their kidney function, we look at their electrolytes, as well as their blood count and their liver function tests, because these drugs go through the liver and are metabolized there. We do monitor the heart a little bit more closely when patients are on this therapy, so we can check an EKG as well as an echo. And then the last important piece is these are all oral medications, right? But these are what we refer to as specialty medications. And so they're not a prescription that we can send to your local CVS or your local Kroger pharmacy. These have to be sent to specialty pharmacies. And so therefore, most of the time, it's not a medication you would pick up in person, but it would actually be shipped to you. And so we always recommend, if a patient's starting a new targeted therapy, if they're seeing a phone number that they don't recognize, even if it's an 800 number, it could actually be the specialty pharmacy reaching out to the patient to set up delivery. Another couple things about some of our targeted therapies, because this is an oral medication that you would take at home and you take it pretty regularly, there is that risk of missing a dose, right? I'm a pharmacist myself, and I can't even remember to take my allergy medicine every day. So my hat is off to patients who do a great job remembering to take their medications, especially a lot of these drugs you saw, some of them are twice a day, some of them are once a day. All of them are going to be multiple pills all at once, so it can be very difficult to remember. So our rule of thumb is if the medication is given once daily, your window is 12 hours. So if you normally take that medication at 9 a.m., you have until 9 p.m. to take the dose. If it's past that 9 p.m., just wait till the next day and take your next dose and just consider it a missed dose. Now, if it's twice a day, we recommend that your window is 6 hours. So let's say you take it at about 9 a.m., you want to take it by 3 p.m. If you miss that 6 hour window, you just wait and you take your evening dose. We really want to stress that even if you miss a dose, you don't want to double those doses, and you don't want to take the dose if it's outside that dose window, because that could increase that risk of side effects. And then the last piece is, can you just throw these unused pills in the garbage? I would say we really want to treat these medications with caution. And so you want to store it away from children and pets. You want to make sure to not touch the tablets and capsules directly. So you can use gloves, you can use the pill cap, you could even use a spoon to handle the medication and to take it. This is also included for that chemotherapy drug temozolomide. We want you to be very cautious when using it at home. If you do happen to touch the medication, just really make sure you wash your hands after you handle it. And so with that, if anyone has any questions, I know it's a lot to talk about, lots of drugs. If you're ever in clinic, we always have a pharmacist there who can always stop by and talk if you have any questions about any of the medications or anything that you're taking.
Thank you so much, Brianna, for all of that excellent information. We really appreciate your time today. Thank you again for all of our attendees who are joining us live. And as a reminder, our broadcast is being recorded and will be available to watch again at a later date in the near future. In the interest of time, to try to keep us moving forward, we are going to skip the 5-minute break that we had planned for now and keep moving forward. Our next presenter, I have the honor of presenting Dr. Duke Blakai. Dr. Blakai is going to be speaking to us today regarding the radiation therapy techniques and frontiers for melanoma spine metastasis. Dr. Blakai leads a busy clinical practice in head and neck, skin, skull base, and CNS malignancies. He is also the head and neck interoperative and CNS pediatric fellowship director within the radiation oncology department, as well as the lead of the radiology spine department. Dr. Blakai earned his bachelor's and master's in molecular biophysics, biochemistry, and chemistry from Wesleyan University. He earned his biochemistry master's, PhD, and MD, all from Albert Einstein College of Medicine. He is on the national committees for head and neck skin cancer clinical trials, including NCI, ECOG, and NRG. At the James Cancer Center, his research interests continue to be clinical and translational in nature, with his goal to tailor cancer treatments to patients based on their molecular profiles of treatment resistance and to conduct research that will ultimately lead to novel clinical trials. Please join me in welcoming Dr. Blakai.
Thank you very much. Can you guys see my screen? Okay, so I want to thank the organizers for inviting me today. I very much enjoy working with the cutaneous malignancy team. As I was kindly introduced, I'm a head and neck, skull base, and CNS oncologist, and I use radiation to help with treating cancers, including melanoma and other cancers. So today I'm going to be focusing most of my talk on advanced stage melanomas, the ones that end up going to the spine, although I treat ones that go to the brain and other places as well. But this has been a unique interest, and I'd like to share how we go about that. So I have some disclosures. I received research grant support from these two different companies, and I teach for the board review for both head and neck and radiation oncology. So I'm going to introduce management of spine tumors. I'm going to talk about radiation therapy logistics, the toxicities, and what stereotactic radiation therapy is versus conventional radiation. And then I'm going to share some data, some recent data that we're very excited about, and then look at some of the future directions in melanoma. So when we're thinking about radiation therapy to the spine, the purpose is threefold: is to alleviate the pain, prevent or reverse neurological dysfunction, and prevent local progression of disease. It is really important to think of this as a multidisciplinary team where we have to be patient-centric. The patient is in the center here. We have surgeons, radiation oncologists, dermatologists, medical oncologists, radiologists, pathologists, neurologists, anyone that can really help us in caring for these patients. And we need to be in tumor boards and so forth. And just to make that point, the spine team has all of these different folks on there. And this is by no means an exhausting list. So when we think about the skin team, we also have to think about it in a similar manner. The skin team encompasses quite a few different people that help us in getting the best things done for our patients. So why are we talking about spine? Well, as a lot of my previous colleagues have stated, we're doing a lot better with these therapies, and we have improved outcomes. And people are living a lot longer with metastatic melanoma. And so as they live longer, there's more and more things that we have to make sure that we help them with, both from their overall survival standpoint, but also from their quality of life standpoint. And so spine tumors are pretty common. Over 36% of vertebral bodies are found to be in the spine. Patients present with three different kinds of pain. Biologic pain, which is constant, deep, and aching. When you get steroids, usually that improves the pain. There's mechanical, where if you're twisting and moving, that's what brings on the pain, where if you lay flat, everything is great. But the moment you get up, everything is painful. And there's radicular pain, which is sharper stabbing, and sometimes can start in the lower back and go all the way down to your knee or your big toe or so forth. And these cancers in the spine can be extradural, intradural, extramedullary, meaning they can be near the cord, just outside of the cord, within the vertebral body. And depending on where they are, our treatments change accordingly. Because in medicine, the rule number one always, this is what I was taught by my mentors and my father, you always do no harm first. And then number two, you help as much as you can while you make sure that you do no harm. So the National Comprehensive Cancer Network has deemed that stereotactic radiosurgery for patients who have few areas of disease in other parts of the body and are radiation resistant, like melanoma, stereotactic radiosurgery is appropriate. And these are our national guidelines. So how do we make a decision as to if we're helping someone or not? And our colleagues at MSK came up with this really nice way of being thorough and making sure that we think of the entire patient systemically. And we call it the NOMS criteria. So what does that stand for? Well, the N stands for neurologic. And on this, we have some pictures here where we can see, do we have impingement of the thecal sac? And you can see it's supposed to be white over here, but we have a little bit of of tumor going into the cord versus the cord completely being surrounded by cancer. So depending on what this looks like and what grading we give it as a 1A, 1B, or 1C, we can think of different treatments. External beam conventional radiation therapy versus stereotactic radiation therapy. This is another pictorial view. The 1A and 1B, we can give stereotactic radiotherapy to. To these, we have to give conventional radiation therapy. And I'll explain what that means in a few moments. The oncologic component is very, very crucial. And what we're starting to learn is that radiation doesn't kill cells all the same way. Depending on the dose, there seems to be differences depending on what is being used with. So if it's given with immunotherapy, there seems to be some differences versus other chemotherapies or other systemic therapies. And we think of histology. So melanoma is considered to be a very vascular and radio-resistant tumor, meaning we need to give higher doses of radiation, Mike Tyson-like uppercuts in order to really control these. And that's important because that plays a role. So now we went through the N, we got to the O, and now we look at the mechanical stability, meaning how stable is the vertebral body? If the vertebral body is unstable, or if I'm treating the cancer and the cancer is providing some stability, am I then causing a collapse, which would be even more painful for the patient and make them even more debilitated? And in this scenario, we're thinking about surgical intervention. And then finally, we need to think about systemic disease. Does the patient only have disease in the spine, or they have disease in multiple areas? And as I'll show later, depending on how much disease there is, and the burden of disease, actually treating in certain ways has a benefit. And so that's important to remember. And so this is essentially saying we have a patient who has no myelopathy, meaning the cord is not being compressed. We have a low-grade component to this, and then it is a radio-resistant histology. And so we look at this algorithm and we say, you know what, we think stereotactic radiosurgery is important. So what are the differences? So for external beam radiation therapy, it is a shotgun approach. And you can see that I'm treating through and through, all the way from the skin to the top to the back where the vertebral bodies are. Whereas for stereotactic radiosurgery, I am specifically treating where I'm avoiding the spinal cord. And I can give a lot higher doses because I'm not constrained by that. And instead of giving it over 5 to 10 fractions, it's usually done between 1 to 5 fractions. And I would call this more pinpoint, and this sort of like a sniper, if you will, and this one a lot more broad, like a shotgun.
So is he like with neuro stuff too? Like, I know he's a melanoma doctor, but no, he's a radiation oncologist.
So the benefits of stereotactic radiosurgery compared to external beam is shorter duration. We have a higher biologic dose, and we have more conformal radiation dose. So it's improved distribution for those surrounding tissues. So the basics, it's non-invasive. It can be delivered by a number of different techniques. Gamma knife is used as thought process. People use CyberKnife or LINAC based. There have been studies to show that these are all equally equivalent and can be done with about 1 to 2 millimeter accuracy, which is important to remember. So this is a typical patient who is being treated. And what we need to do and make sure is that the patient is lying still but comfortable. Because in order for us to be accurate, we have to make sure that our target is not moving. Because if the target is moving, that can cause a lot of problems and more side effects. In the head and neck region, we use these special masks that don't allow the patient to move too much. And when patients have some claustrophobic worries, we use appropriate medications to help them with coping with these masks. So we use, in order to do our treatments, we have to use the imaging that's available, both MRI and CT planning. We use, contrast infused, and we also use T2 sequences so we can see the cord well. The white here is the fluid around the cord that's in the middle. And we use all of this information. And so what I want to show you here, we're so targeted that if you look from the cord in pink here to the 50% isodose line, meaning if I wanted to treat 100% of the dose, I'm within 5 millimeters, I can change drastically from millimeter to millimeter by more than 20% if there's a lot of movement. So the precision that we work with is crucial and relevant to making sure that we're both accurate and we're taking our care of our patients, but also minimizing the side effects. We have consensus guidelines that help us in deciding what areas of the vertebral body to treat, what areas of the pelvis to treat. And these are important because it allows us to be effective across multiple disciplines. I've been doing this for a while, but for the folks that haven't, they have something to look at and try to get some guidance. So at Ohio State, we have our specific guidelines that we use that are in line with what is being done nationally. And that's important because you have to be able to cross compare with your colleagues. We utilize specific ways of making sure that we account for the spinal cord, because if you can't see something, you can't protect it. And then you have to know and understand what are the limitations, what are the doses that a particular cord can get. So the treatments that we give are 9 gray times 3 or 12 gray times 1. Other folks will do 18 to 24 gray times 1. And we're starting to see different effectiveness on these treatment doses. And those are all important things to understand. We also have to make sure that the spinal cord is close to the vertebral bodies, but so is the esophagus, and we have limitations. So to make sure that we have safety constraints that our physicists will help and so forth. Well, how good are we? Well, our local control rates are in the 88% range. And that's true also for our work at Ohio State. And there's a paper that I'll share as we move forward. Well, what can happen? Well, what can happen is we can hurt the spinal cord. We can cause a fracture of the vertebral body, because you can imagine a cancer that has taken over the bony anatomy and it sits there and acts like a scaffold. Well, if I kill the cancer, I've killed the scaffold. And if I kill the scaffold, I can cause a vertebral body fracture. And so that's why the multimodality team is crucial. Overall, we have about a 14% chance of vertebral body fracture rates. The kind of treatment that we give, I quote our patients about 5 to 7%, but depending on what you're doing, you can go as high as 39 or 40% and as low as a couple of percentage points. So it's very important to know and work in a team with interventional radiologists as well as surgeons that'll help you to make sure that we're doing the best for our patients. How do you reduce the risk? Well, you reduce the risk by not giving as much dose. So the blue is the highest dose. That meant the highest amounts of risk. The orange is in the middle, and then less than 19 gray per fraction is where it gave you the least amount. And so we're very cognizant of this, and we move forward. Well, what else can happen? Well, about 1 out of 10 patients, somewhere near 10%, will have what we call a pain flare. And so they'll get the treatment. The cancer will be so upset, if you will, it'll be inflamed, swollen, and that can impinge nerves. And so usually steroids will help with those scenarios, and that can happen in a 6 to 14 day. And that usually, I'd say, vast majority of times, that's what allows us to help. Currently, the great news about the spine world is we have 2 randomized trials. One that was completed in the United States with a little bit older technology and not as high a dose, and one more recent one that's been completed in Canada, where initially they're showing conflicting data, but what we're really excited about is the comparison of the local control of the higher dose versus the lower dose. The higher dose, we're talked about 88 to 90% control. The lower dose as low as 30% in 1 year, depending on what we're treating. From a pain standpoint, this particular study did not show a difference from pain improvement. That is about an 80% pain reduction. Whereas Whereas the long-term clinical effects are still pending, we're waiting at 1-year reports when these phase 3 clinical trials complete. But in Canada, they actually showed 2 different, more newer stereotactic treatments and a little bit higher dosing, 24 gray in 2 fractions and versus 20 gray in 5 fractions. And what we're seeing here is it's about a 2-fold increase in complete response to pain for our patients. And that's significant, both at 3 months as well as at 6 months. And so we're starting to see these differences that are important. So in summary, our patients, and I have a few more slides after this, but patients with spine metastases should be really managed in the multidisciplinary team, just like our skin metastases. Medicine these days is a team effort. It's not a one person show. It's a multi-person show and a multi-team show, and that's relevant and important. So what have we done at Ohio State? Well, recently we were able to publish a paper which we're really excited about, and got a special commentary on, where we're starting to show that in the post-surgical treatments, and we were the first ones to show this, that if you wait more than 40 days post-surgery to treat with radiation, you will lose about 20% of local control at 1 year. So you want to make sure after your surgery that the treatment with radiation is actually occurring in a timely fashion. The other thing that we found that was very interesting for things like melanoma, for example, which are vascular tumors, if the surgeon embolizes these tumors, there's a 12% benefit of local control, which we're also the first to show, which was very intriguing. And we looked at tumors like renal cell carcinoma, and we're starting to do a pretty good job with these tumors, which is very important. So the treatment time, the pre-op embolization, these are things that we've added to the literature that we're very excited about. I do want to show one slide here. And if you can see, this is a tumor that's pushing on the cerebrospinal fluid, which is the white stuff here, and the tumor is pushing onto it. And you can see we have the nerves over here, and we can see the tumor kind of draping over this area and really compressing. The color is the radiation that we've given, and about 3 months later, you can see how nicely the fluid now goes through, and then how the area where the fluid goes, the white portion compared from panel F to panel B, you can see how nicely everything is opened up. So these are examples of the things that we can do to help our patients to maintain, because this could be a patient that's having a significant amount of pain because their nerve roots are impinged, and then no longer so as we move forward, and function is maintained. So all of these things are very important, and the more so the target volume becomes important, as well as how well the patient is doing from a systemic standpoint. So we always have to remember, just because we're treating a small area, it's very important to think of the patient as holistically, and I think that's where the team really is valuable. We had some toxicities, but pretty low. We had 1 pain flare. We really didn't have high-grade toxicities, and we followed these patients for over 15 months. And so overall, we're doing okay. So what are we doing now? Well, as I said, a lot of our patients, our systemic therapies are getting much better, which is amazing, and we're so excited as a team. But in such, patients are continuing to have perhaps other areas where they may be causing pain because they're going to the spine or the brain or so forth. And what we're starting to see, if we give high doses of radiation, let's say 20 gray, we're starting to see the radiation actually impeding the effects of the immune system. Whereas if we give 8 gray, we're starting to think that radiation is actually inducing the immune system. And so we're starting to work together with our medical oncology colleagues to treat in a concurrent fashion, meaning with immunotherapy and radiation therapy, as there may be some synergistic effects there. As you can think about radiation breaking down cancer cells and then providing the immune system more potential targets as one way to look at it in a fairly simplistic way. The other thing that I want to emphasize is we're working with the engineering team, and Ohio State has an incredible engineering team, and we're trying to see how the cancer affects our movements, and potentially what is the algorithm, what is the risk that if I go from a particular image what is the risk that I'm going to affect the spine? And how am I going to affect that spine in that right way? And where is the stress and strain due to cancer? And more importantly, what can I do to try to prevent those potential side effects? And so these are all things that we're moving on forward. There's work here that we've done where we're looking at all of our spine patients in a prospective manner now. Based on those NOMS criteria, the neurologic, oncologic, mechanical, and systemic. And we're following all of our patients closely, where we have ability to look at their clinical outcomes and molecular potential outcomes, and who's received immunotherapy, who's received other therapies in combination with immunotherapies, so that we can continue to learn as much as possible. And we were able to get a nice small grant here, working together with Dr. Kendra from one of the companies. And so in the next few weeks, this will move forward, which will allow all of our patients to be monitored in a safe, appropriate manner, so that not only can we help the patients that we're caring for, but also get better so that we can help other patients in the future. So I want to finish by saying we have to be a team. We have to work in a patient-centric way, and each of your doctor's specialties should come in to help you as a whole. So with that, I want to thank you. These are my 3 toddlers that keep me engaged and on my toes. I'm happy to take any questions that may arise.
Thank you very much, Dr. Blakai, for your time and your expertise today. We really appreciate it. Our final speaker for our symposium this year is going to be Dr. Carlo Contreras. He will be speaking about the role of surgery in melanoma. Dr. Contreras is a surgical oncologist who specializes in skin and soft tissue cancers, including melanoma, Merkel cell carcinoma, squamous cell carcinoma, and basal cell carcinoma. He would like to share that for years, treatment options for these types of cancers have been very limited, but recently entirely new classes of medications and therapies have been made available that provide unique opportunities to learn and apply innovative treatments that really do benefit our patients. In addition, Dr. Contreras is the lead for the melanoma surgery program here at the OSU James. Please join me in welcoming Dr. Contreras.
Good morning. Thank you so much for joining us. And I'd like to thank our sponsors also for hosting this wonderful event so we can all learn from each other. I will be focusing on the role of surgery in melanoma. And again, I appreciate the opportunity to share this with you. I know it's a wonderful day outside and you're all eager to get on with your day, so I won't spend too much time here. So the driving principle that I really want to emphasize during this presentation is how melanoma surgery is really a synthesis, a combination, a careful consideration of both the technology available and the science that drives what we know and understand about melanoma. And it's really that combination that informs how we operate on patients with melanoma. We don't just operate on patients with melanoma because we can or because we think it's the best thing to do. We have the science to back it up. And it's a continuous cycle between understanding the science and developing new technology and applying that technology and then studying it in a new way to make sure that we are always delivering the best care as surgical oncologists who focus in on melanoma. In our melanoma group, it's principally myself and Dr. Joel Bean. We're both fellowship trained surgical oncologists, and we're very excited to help out with melanoma patients of all stages. So these are the goals that I have for my portion of today's presentation. So again, science helps us understand when and how surgery can be used to treat patients with melanoma. And there should be a thoughtful integration of technology that helps us improve the safety and comfort of melanoma surgery. Despite amazing advances in melanoma medications, as you've heard Dr. Wu and Dr. Archambault talk about, surgery remains an important aspect of high quality, effective treatment plans for our patients. Okay, so let's dive in and explore a little bit about how technology shapes melanoma surgery. I'm going to focus, there are lots of examples that we could go through, but in the interest of time, I'm going to focus in on minimally invasive surgery. And so when we talk about minimally invasive surgery, we're usually contrasting that to traditional surgical approaches where maybe a long incision is required. And so in contrast, minimally invasive surgery relies on small keyhole incisions to gain access to whichever site needs to be operated upon. Because the incisions are smaller, there is generally less pain associated with these operations. That in turn allows for a quicker recovery, less downtime so that patients can get back to whatever it is that they love doing, whether it be time with family at home or getting back to work, or for patients who are still in the educational process, getting back to school. And for those that are really active from a physical standpoint, it generally means a quicker resumption of your pre-surgical activities. So fewer lifting restrictions and things like that. So the two main types of minimally invasive surgery are laparoscopy and robotic surgery. And there are a lot of similarities, but there are a few key differences. So laparoscopy is used, again, we use small incisions to reach the internal organs using a thin, straight camera and long instruments, which basically you can twist around and then you can open and close. But beyond that, there's not a whole lot of freedom of motion that laparoscopic instruments allow you. This was a technique that, due to the technology that was available in the 1980s, popularized with appendicitis and gallbladder removal. And these are still very reliable, safe, and appropriate uses for laparoscopic surgery. Robotic surgery has really taken advantage of several technologic advances. One of the big technologic advances is just the miniaturization of electronics. Being able to cram in a greater number of sensors and devices within a given footprint for a product in order to make that product do more of the things that you want. Also, there's been a dramatic increase in the microprocessor capabilities of our chips, which allow these platforms to perform all sorts of computations and have effects that we couldn't have dreamed to go 10 and 20 years ago. So robotic surgery really builds upon laparoscopy. It also allows for high definition video that actually has depth perception, three-dimensional depth perception, which, as you can imagine, for a surgeon is really important and has always been a significant drawback to laparoscopic surgery, where everything just looks like flatness. You can't perceive that depth. Probably most importantly, the miniaturization of our electronics has allowed for the robotic instruments to have more wrist-like movements. So it basically imitates what the surgeon would do with his or her hands in an open situation with traditional surgery. So like I mentioned, laparoscopy was popularized in the 1990s. The drawbacks are that these long, relatively inflexible arms can't reach all parts of the abdomen. As you would imagine, the internal organs have depth as well as length and width. And if you're trying to reach above an organ and get to something in a very difficult to access portion, laparoscopy is often not your best option because the instruments are pretty much rigid. And then, like I mentioned, there is a significant drawback in the quality of what you're seeing because you only have two-dimensional perception. You don't have that depth perception, which can be so critical in understanding the anatomy, where the tumor is, and where where other important internal structures are located. In contrast, robotic surgery, like I mentioned, the instruments have multiple pivot points. So instead of really just being able to turn around, open, and close, now these robotic instruments can literally bend and rotate in almost an infinitesimal number of directions. And it really mimics exactly how the surgeon would move his or her hand during a given operation. And so, whereas laparoscopy really forced surgeons to completely relearn how they did an operation, much of that is still true with robotic surgery, but with robotic, it just feels so much more natural, and the machinery allows you to do what you would normally do with your own hands. And the visualization is just so much better because we are finally able to operate in high resolution, three-dimensional structure. So in the operating room, this looks different than traditional surgery. So for robotic surgery, this is actually called the console. The surgeon would be seated at the console, and the hands are inserted into a device where with your fingers, you are pinching and grabbing and moving around your devices. Those are connected by electronics and draw wires to the actual robot, which is inserted through the same type keyhole incisions into the patient's internal organs. And the surgeon looks into this box type area through two different cameras, two different screens to establish that three-dimensional perspective. And as well, the other providers in the operating room that need to see what's going on can see that in a two-dimensional fashion on high resolution large screen monitors, so that everybody understands what's going on and everybody can contribute to a successful robotic operation. So specifically, where do we use robotics in melanoma surgery? So there are lots of examples. There are patients who develop melanoma growth in the intestines, and it causes blockages or obstruction. And so especially in the acute stage where perhaps a patient is so obstructed that they can't even get any of the chemotherapy or immunotherapy medications that Dr. Wu and Dr. Archambault talked about, they just need an operation to, so to speak, unclog the pipes so they can get eating and they can actually start taking medications for their melanoma. What I've shown here is an illustration of a patient here at OSU that I took care of, that after having a pretty rare type of melanoma that grows primarily from the eye, it spread to the liver, as you can see on this MRI scan in between the two arrows. I was able to remove this through a robotic operation, and the patient went home less than 24 hours later, just one single evening in the hospital and then back home. It's an incredible recovery. Patients will sometimes develop bleeding from melanoma when it affects the GI tract. Melanomas, because they can grow quite quickly, the tissue recruits many blood vessels to supply the cancer with enough nutrients, and because of that very rich blood supply, the tumors in themselves can start bleeding. And sometimes they bleed to the point where a patient's blood pressure is depressed, and it's an emergent situation where only an operation is the most reasonable and most effective treatment. Then there are certain areas that are otherwise hard to get to, where robotic surgery really excels for melanoma spread, or metastasis is another name for melanoma spread. And that can be the removal of spread to the adrenal glands, which are small structures that live just above the kidneys on each side. And then lastly, where I've developed an operation where I robotically remove the lymph nodes from the pelvic and the groin areas, which in a couple slides here, I'll show you has huge benefits when you compare it to traditional operation. So this is how we used to take care of patients, and still do in some cases if they have very large and bulky amounts of melanoma in their groin, where it would require really a very long incision that goes almost all the way up to the belly button and down through the thigh. As you can imagine, incisions that cross the groin crease there are very painful, and they take a long time to recover from, because the groin area is one of the least hygienic parts of our bodies overall. It's prone to infection, and these patients are also prone to chronic swelling of their legs called lymphedema. In particularly obese patients, we try to separate these into 2 separate incisions, again, just to protect the skin of the groin crease, but it's a very difficult operation to recover from. Fortunately, again, using robotic techniques, instead of those large incisions, I complete this operation through 3 small incisions for the groin portion of the operation and 3 small incisions for the pelvic part of the operation. And again, these patients generally go home the next morning after their operation. They're walking, they're comfortable just on regular pain pills, and they're able to get back to the activities that they know and love. So I want to just share with you a quick excerpt of a video that I presented at one of our national meetings. And this really what I want to show here is just the delicate nature of how the robotic instruments really work for the benefit of the patient here in this melanoma operation in the groin. The goal of showing you this video is certainly not to spoil your lunch hour, and certainly not to understand all the particular structures that you're seeing here, but you can just see how the fine movements, these structures here, these blood vessels that we're dealing with, are probably about the width of a grain of rice. So they're very small, and you can see, especially as I'm inserting this clip applier, how it bends. That would be completely impossible to do, that amount of detailed movement with laparoscopic surgery. Of note, I do complete this operation laparoscopically, but it's so much easier and so much more reliable with the operating robot. So that's just a flavor of what we can offer our patients, the precision and the quicker recovery. All right, so now that we've talked a bit about the technology that we use in melanoma surgery, let's talk about the science, because that's so crucial. It's not just about what we can do and what tools exist. It's about how can we rationally apply them to work for the best interest of our patients who are dealing with this disease. So just to kind of touch back to a few points that Dr. Wu and Dr. Putrakal made earlier in the morning, what are the goals for early stage melanoma surgery? Well, you want to remove the cancer that you can see and feel. That's kind of a bare minimum. But you also need to remove additional skin around the melanoma, because if you don't remove enough, you increase the chances that that melanoma may regrow in the same site, or heaven forbid, might move to other parts of the body, like lymph nodes or other organs, like Dr. Blakai was mentioning, spinal metastases, liver metastases, or other sites like that. So how do we know how much tissue to remove, how much skin to remove? Well, that really falls in the domain of clinical trials. Instead of relying just on tradition dictating how we do melanoma surgery, melanoma surgeons set out to carefully investigate 3 main types of questions over the last decade. The first of those is the extent of surgery, of skin surgery, for early stage melanoma. How can we use surgery to help understand the prognosis of patients who are affected by melanoma? And then what should be the extent of surgery for advanced stage melanoma? And so I'll break these 3 down to kind of put it into more digestible bits so you can understand, because I think this is really useful to know. So I'd like to first talk about how we used to treat melanoma. And I'm talking like 20, 30 years ago. So we used to remove a large amount of skin, and we used to remove a large number of lymph nodes. Well, why was that? Well, the traditional notion of cancer that has been prevalent for really about 100 years now is that you have cancer that starts in a very localized area, and then if it's allowed to keep growing, it will start moving across the body in other parts of the body. So often for melanoma, that would involve lymph nodes. And then if it keeps growing beyond lymph nodes, it could affect other organs like brain, spine, liver, lungs, the small intestine. And in order to prevent melanoma from spreading to those other organs in decades past, we would just go ahead and remove large amounts of skin and large amounts of lymph nodes in the region to, again, prevent it from spreading to other organs, because we didn't have effective therapies beyond surgery. Dr. Putrakal and Dr. Wu talked about how the depth of melanoma is important. And I want to reemphasize that because here in cartoon format, we're looking at a very thin melanoma. And on the right panel, we're looking at a deeper melanoma. And so deeper melanoma means that more surrounding skin must be removed. Well, how do we know that? And to what extent do we need to remove that skin? So historically, melanoma surgery involved removing 2 inches of normal looking skin around a melanoma. As you can imagine, this is a cartoon kind of showing that 2 inches around an arm like that is going to be painful, disfiguring, potentially disabling as well. You can imagine if that melanoma was on the face and you're trying to remove 2 inches, what a terrible situation that would be. And so how do we determine what's a more reasonable amount of skin to remove? So now typically we remove a much smaller amount of normal surrounding skin, but how do we know that's the right thing to do? Well, we conducted clinical trials, and clinical trials mean groups of patients were treated with different amounts of skin removal to understand what's appropriate. We compared patients who had narrow margins versus wider margins and looked at the success with those operations. And kind of this chart here is the summary of what that looks like. So if you have melanoma depth of less than 1 millimeter, the amount of normal looking skin around it should be about 1 centimeter. And for much deeper melanomas, if it's greater than 2 millimeters in depth, you need to remove you need to remove 2 centimeters of normal looking skin around it. And you take this all the way down to the muscle layer. There are some exceptions where it doesn't make sense to go all the way down to the muscle layer, but generally that's our target. Okay, so again, we used to treat melanoma by removing large amounts of skin and large amounts of lymph nodes in order to prevent that melanoma from spreading to other organs. And the lymph nodes that we're talking about might be the lymph nodes that are situated in the neck area. On each side of the neck, we typically have 40 to 50 lymph nodes. In the underarm areas, the axilla is another name for that. We typically have about 20 lymph nodes on each side. And in the groin area, the inguinal basin, we typically have between 10 and 20 lymph nodes there. And so taking out all the lymph nodes in a given area is a big deal for patients. We saw that earlier when I showed you that robotic video with the inguinal lymph node incision. You can see how traditionally those long incisions were difficult to recover from. Well, what if we could take a more precise approach and only take out large number of lymph nodes if we absolutely had to? What if we just started out by taking out a fewer number of lymph nodes and figuring out if the melanoma had spread there and stopping if it hadn't gone any further? So again, we have this notion that a confined cancer is better than widespread cancer. So how do we typically detect how far cancer has spread? Well, we might do a physical examination, whole body photography, or a good careful dermatoscopic exam, like Dr. Spaccarelli was talking about. We pay attention to the symptoms a patient has in terms of pain. But what if we could microscopically detect microscopic spread beyond the skin? How would that change things? Well, we can do just that, and it falls into the domain of what's called sentinel lymph node biopsy. And so it answers the question, is there microscopic spread of melanoma to lymph nodes? And so what we do is we inject the melanoma site. So let's say that the melanoma site is on the skin right here, and we're injecting 2 kinds of dye. One is a radioactive dye that's colorless, you can't see it, but you can detect it with a special probe in the operating room. And the second dye is a blue dye that you can visually see. And so we inject the skin around that melanoma site, and then we wait to see where the body carries that dye. And where the body carries that dye is presumably the same route that melanoma cancer cells would have used to travel from the skin to the lymph nodes. So if we take out those lymph nodes that have the dye, we're better able to assess whether the cancer has already spread to the lymph nodes. If we test those high-risk lymph nodes underneath the microscope and we see that there's no spread to those lymph nodes, then the patient doesn't need any more surgery to have the greater number of lymph nodes removed. And so if we go back to traditionally, again, we were taking out large amounts of skin, large amounts of lymph nodes to prevent spread to other organs. But this is the new paradigm. We remove the skin, of course, through the smaller margins that I talked about, and instead we're going to test the lymph nodes. And in doing that, we're assessing for the risk of spread to other parts of the body. So again, careful clinical trials and science have allowed us to reduce the amount of surgery that we need to subject patients to, while yet still maintaining a successful treatment plan for melanoma. So in other words, the much less invasive melanoma methods that we have are resulting in less pain, less risk of infection because of smaller incisions, less risk of chronic limb swelling, and earlier return to doing the activities that our friends and family rely upon us for. Overall, this is providing patients important information about their prognosis, and it allows our medical oncology colleagues to determine when patients might need some of those advanced medications to further control melanoma. So this is kind of how, if we split up patients by era, how we would have treated them. So in 1970, they would have had that very wide skin removal. We would have taken out all the lymph nodes in either the neck area, the armpit area, or the groin area. We fast forward to 2010, not that long ago. So a patient now has that same melanoma. Instead, we're removing only a few sentinel lymph nodes. If there's no melanoma in those lymph nodes, then that patient doesn't need any more surgery. If the patient does have melanoma in those lymph nodes, generally we subjected them to that more complete operation. But in 2017, again, there was another huge clinical trial that really changed the standard of care for melanoma. And now we know that there is actually no benefit to taking out the remainder of those lymph nodes if there's just microscopic spread to those lymph nodes. Now, if somebody comes in with large nodes that you can feel with your fingers or are large enough to see with our CT scans, MRI, or PET scans, that patient still does need a complete lymph node removal. But if there's only microscopic spread to those lymph nodes, then we generally just observe these patients and refer them to our medical oncology colleagues to see if they would benefit from some of our advanced melanoma therapeutic medications. The last few minutes, I just want to talk about melanoma in more advanced disease. So sometimes melanoma just kind of gets out of control. Sometimes it doesn't respond to the medications that we have available. Sometimes, unfortunately, patients just don't have good access to high quality care like we offer here at the Ohio State University. In those situations, surgery can be very important to help relieve pain from a melanoma that's growing in an uncontrolled fashion. Sometimes these melanomas, as I mentioned, especially in the GI tract, are just bleeding uncontrollably. Sometimes they're just difficult wounds with infection that need to be better controlled. And of course, I mentioned in the earlier part of the lecture about intestinal blockages. Let's not forget that sometimes with favorable tumor biology, even just a single modality like surgery can cure some patients. Not everybody, but it does cure some patients. That's why it's important to involve all the experts that we've involved today to understand the best way to treat some patients. But there are some patients that can be cured just, even with advanced disease, that can be cured just with surgery alone. Dr. Wu talked about all sorts of exciting clinical trials. Often we have to get specific types of tumor samples in order to determine whether they're candidates for those trials. And so surgeons and surgery is an important aspect to making patients eligible for those clinical trials. And finally, unfortunately, some of our medications just don't work for everybody. Sometimes they work for a given period of time and then they stop working. And that's another area where surgeons are very important to engage. So again, science has really shaped melanoma surgery. We've reduced the amount of skin that's surgically removed. We've avoided removing all the regional lymph nodes for a great number of patients, and we've done a more focused operation. And so the future really looks bright, where we're trying to better understand how surgery fits in with some of these advanced therapeutics. Do we give some of the medications first? Do we operate first, or some combination thereof? And so this is my final slide. I just really want to emphasize again how melanoma surgery is really a synthesis between the technology we have available and the science that understands how melanoma works within our bodies to really develop the best treatment plans in the context of a multidisciplinary care team. And that's what melanoma surgery is. the future is bright for how we can continue to study melanoma and really improve our patient outcomes, which at the end of the day, I think that's why we're all here. So thanks very much. I'd be happy to take any questions. And again, I just want to appreciate the opportunity to speak with you all today. Thanks very much.
Thank you, Dr. Contreras. We really appreciate your time and your expertise. We are running a little bit ahead now, so I will go ahead and introduce our nurse practitioner, Jessica Aparicio. She is with our melanoma medical oncology team, and she will be doing our closing portion of this year's symposium. Jessica specializes in the care of patients with skin care, including melanoma, squamous cell carcinoma, basal cell carcinoma, and Merkel cell carcinoma. She was accepted into the highly competitive Advanced Practice Professional Oncology Fellowship at the James in 2017. She has accreditation from the Oncology Nursing Society as an Advanced Oncology Certified Nurse Practitioner. Prior to her role as a nurse practitioner, she was an ICU nurse for 5 years. She received her bachelor and master's degrees from The Ohio State University, and she is an active member of the Columbus chapter of the Oncology Nursing Society.
All right, thank you, Diana. All right, so in closing, we just wanted to say thank you again to our wonderful presenters today. Each presentation was full of excellent information, and we really appreciate your time with us on this Saturday. We also wanted to thank our attendees for taking time out of their Saturday morning to join us. We really appreciate your support, and we hope you got a lot of great information today. As a reminder, this event has been completely recorded and will be available next week for your review. And before you leave us today, we're hoping that you can fill out a survey. We have placed it into the chat. This helps us to receive feedback from you and see how we can better create future presentations that best assist in what your learning needs are, what your questions are, and help us create the best events that we can. So thank you again for joining us. We hope to see you next year. And again, the date that we'll be having our next symposium will be May the 7th. So, and if you have any final questions, we will be on for a little bit afterwards. Please feel free to send them. Thank you.